Okay. Good morning. I'm at-large Councilmember Christina Henderson, Chair of the Committee on Health. Today is Monday, June 9th, 2025. The time is 10:01 a.m. All right, we are in room 500 of the John A. Wilson Building. This is a hybrid hearing. We'll be hearing from government witnesses in person. The hearing is also broadcast live on cable channel 13, as well as on my YouTube page at CMC Henderson. I'm calling to order this meeting of the Committee on Health for part 2 of 2 oversight hearings for the proposed fiscal year 2026 budget for the Health Benefit Exchange, the Office of the Deputy Mayor for Health and Human Services, as well as the Department of Healthcare Finance. We held a hearing for public witnesses on Thursday, June 6th, and we're going to hear from our government witnesses today. Mila Kaufman, who is the Director of the Health Benefit Exchange, and Deputy Mayor Wayne Turnage, who's wearing 2 hats as the Deputy Mayor for Health and Human Services, as well as the Director of the Department of Healthcare Finance. I'm going to give just a little description about each agency before I swear you all in, and then we'll talk about our order of events for today. The DC Health Benefit Exchange Authority is a quasi-governmental agency of the District of Columbia government charged with implementing and operating the district's health benefit exchange. This exchange operates DC HealthLink, an online insurance marketplace for district residents and small businesses. DC HealthLink fosters competition and transparency in the health insurance market, enabling individuals and small businesses to compare health insurance prices and benefits and to purchase affordable quality health insurance. The Department of Healthcare Finance provides healthcare services to low-income children, adults, and elderly, and persons with disabilities. More than 300,000 district residents receive healthcare services through Healthcare Finance's programs, either Medicaid or Alliance. The Office of the Deputy Mayor for Health and Human Services supports the mayor in coordinating comprehensive system of benefits and goods and services across multiple agencies to ensure that children, youth, and adults with and without disabilities can lead healthy, meaningful, and productive lives. DMHHS provides leadership for policy and planning, government relations, and communication and community relations for agencies under its jurisdiction. DMHHS manages 2 special initiatives, Age Friendly DC, the Interagency Council on Homelessness. They also oversee the administration's encampment cleanup and closure efforts. On Thursday, we heard from nearly 80 public witnesses. They expressed strong concern around some of the coming changes to the district's public insurance system and a desire to ensure that our government agencies are working efficiently to maintain health insurance and benefits for those to keep the district healthy. I want to acknowledge that there are a lot of discussions that are happening around our health system, both here and on the federal level, that will affect the district, but nothing on the Hill has been decided yet. So we're having discussions today, and then we'll deal with the other pieces when they come. All right, so the roadmap for today's government witnesses. First, we'll hear testimony from Mila Kaufman on the Health Benefit Exchange, followed immediately by Wayne Turnage on behalf of the Department of Healthcare Finance. We're going to cover both of those agencies first hold on. Okay, we're going to cover both of those agencies first. And then Deputy Mayor Turnage, you're going to turn to your testimony for the Deputy Mayor for Health and Human Services. We will take a break at some point amongst the two, but we know that both Deputy Mayor Turnage and Ms. Kaufman, you have some overlap in terms of healthcare finance and HBX, and so we will handle that there. Okay, so let's swear folks in. So Director Kaufman, Deputy Mayor Turnage, I ask that you and anyone on your team who might speak today, you all can raise your right hand. Yeah, the whole crew. All right, do you swear or affirm under penalty of law that the testimony you're about to provide to the Council of the District of Columbia and this committee is the truth, the whole truth, and nothing but the truth? Great. All right, Director Kaufman, when you are ready.
All right, good morning. Deputy Mayor Turnage was offering to help me with the technology here for the record. Thank you, Councilmember Henderson, Chairperson Henderson, for hosting this budget hearing and for all of your support over the years. With me, I have our Executive Board Chair, Diane Lewis, who is available to answer any questions you may have. Alongside with me, and of course, our agency Chief Financial Officer, Marjorie, is available as well to answer any budget questions you may have. I'm not going to introduce my entire team because that will eat into my testimony. So just a little bit of background about us. HBX is responsible for DC HealthLink, the ACA online health insurance marketplace. Although we were the last to start building our IT system back in 2013, we were one of 4 state-based marketplaces to open for business on time and stay open on October 1, 2013. In 2017, we formed a first-in-the-nation SBM partnership. We were selected by the Massachusetts Health Connector to provide an IT solution and ongoing operations support for the Massachusetts Small Business Exchange. In 2020, within 2 weeks of approved funding, we were able to issue Mayor Bowser's $12 million in COVID relief for residents and employers, helping them stay insured during the pandemic. In 2022, we designed and quickly implemented Healthcare for Childcare health insurance program for early child development facilities and workers, and that program is now a national model. Last year, we celebrated our 10 years of success. And I give you this background about our successes because there's still many folks in the community who are not familiar with our record of success. We currently cover 100,000 people with private health insurance, more than 5,300 district small businesses and nonprofits. We have more than 900 DC HealthLink brokers who provide free help to our customers. We're responsible for more than $670 million in annual premiums, and we're funded through an assessment on health carriers. I want to spend a minute giving you a quick update on federal actions that impact us. The reconciliation bill that was passed in the House will make it more expensive for ACA coverage. It will make it harder to get and harder to keep. The bill creates lots of new red tape and imposes significant costs to operationalize, estimated to be between $650 million to $2.2 billion nationwide for just reviewing new burdensome verifications. And that doesn't even include IT costs. The bill also takes away state authority, including our authority to set our own open enrollment periods and our authority over special enrollment periods that give residents access to coverage when they lose other coverage or have other qualifying life events. 22 million people with ACA coverage who have lower premiums are at risk of losing their affordable health care because each year they will be required to reapply for that coverage as opposed to being automatically renewed. The Congressional Budget Office estimates 16 million people will become uninsured if this legislation passes. What's not in the bill is the health insurance tax credit for middle-class families, sole proprietors, and small business owners. Middle-class families, self-employed, and small business owners who buy coverage on their own and have lower premiums now will lose those at the end of this year. The tax credit expires in December of 2025. And if Congress takes this away, expect huge premium hikes and millions of people to lose their health care. In DC, premiums as low as $13 a month will disappear. And currently, we have 7 in 10 people with lower premiums who are self-employed or small business owners who buy coverage on their own. 1 in 4 residents currently covered on DC HealthLink gets lower premiums. And we very much appreciate all the work by our 3 largest chambers to elevate this issue nationwide, as well as all the work that our brokers, health plans, and providers are doing to advocate for this health insurance tax credit to be extended. Now, healthcare for childcare, just a quick update. We currently cover 2,089 people, and that includes 1,723 employees and 366 qualified dependents. There are 216 facilities that are covered, and that includes 154 employers. And since January of 2023, when we launched this program, Healthcare for Childcare has helped 2,809 people in 233 facilities. Basic health plan, and I want to spend most of my time walking you through the basic health plan. Under the Affordable Care Act, Section 1331, states have an option to establish what we call a BHP, a basic health plan. It is a health insurance program for low-income residents who are not Medicaid eligible and would otherwise be eligible to purchase coverage through an ACA marketplace like DC HealthLink. There is a federal part in the basic health plan, and HBX, we're committed to work with our federal partners and specifically with the Center for Medicaid and CHIP Services, CMCS, as well as CSIO, which is the office within CMS that regulates us, to help us operationalize this program. The federal government provides 95% of the value of the premium tax credits for this program. Implementation, operational, and administrative costs are not funded federally. As a reminder, DC policymakers established HBX as a private-public partnership funded through an assessment on health carriers, and we are leveraging our current IT infrastructure to establish the BHP and working with our sister agencies, DHCF and DSB, to establish the program quickly. We've made lots of progress to date. We've established an advisory council to provide input on the BHP. Their first meeting was June 2nd. We've established 2 carrier working groups, 1 IT and 1 operational, and they both met last week and have, all 3 are meeting this week again. These are weekly meetings. In some cases, they'll be twice a week. Eligibility rules for the basic health plan. A resident must be under 65 and not offered affordable employer-sponsored coverage. U.S. citizen residents with incomes over 138 of federal poverty level, up to 200% of federal poverty level are eligible. Lawfully present residents but not eligible for Medicaid, we call those 5-year bar residents. We currently have 300 of those covered on the commercial side. They will become eligible for the basic health plan. And as a reminder, undocumented residents under federal law are not eligible for the basic health plan. Our goal is continuity of coverage and continuity of care for residents. The federal government allows states to use MCOs to provide coverage to enrollees, and to ensure continuity of coverage and care, we've invited all MCOs, AmeriGroup, AmeriHealth, and MedStar Family Choice, as well as all licensed HMOs, including CareFirst, Blue Cross, Blue Shield, and Kaiser Permanente, to participate. If MCOs that currently cover DC's Medicaid population choose to participate in the BHP, then enrollees will be able to stay with the same MCO as they have now. Affordable coverage and affordable care for residents means zero or very low premiums and zero or very low out-of-pocket costs for care. And we can design this program to accomplish those goals. We've already engaged actuaries from Oliver Wyman to do preliminary actuarial modeling to determine the level of funding that will be available. In fact, I just want to say, when actuaries give you estimates, there are more disclaimers that one could fit on a slide. So I'll just give you one assumption we had them use. We've asked them to assume that enhanced PTC is not extended because next year the law reverts back to ACA levels. Even assuming that, our actuaries from Oliver Wyman estimate that we will have enough revenue coming in using ACA benefit structure to create a BHP that has no premiums and no cost sharing for medical care. We also asked Mercer actuaries to estimate the cost of BHP if the benefit mirrored current Medicaid benefits, including capitated reimbursement rates, fee-for-service rates, hospital payments, and other payments for this population. And actuaries estimate that the district would need close to $60 million in local funding if we were to use a Medicaid coverage design instead of the ACA benefit structure. So we are moving forward with the ACA benefit structure. I want to highlight why BHP is a better option for lower income residents and families. If a lower income person comes and gets insured through DC HealthLink on our commercial side, if there is no BHP, these are two examples of out-of-pocket costs. So a 40-year-old with income of a little under $22,000 a year, that's 139 federal poverty level, would pay approximately $755 annually in premiums and have out-of-pocket costs for care. Now, it may not seem like a whole lot, $5 a visit, but when you look at out-of-pocket costs for hospitalization, that's 10% co-insurance of thousands of dollars. It is unlikely that that 40-year-old will be able to afford care or even the premiums. When you look at a family, 2 adults, 2 parents, and a child will continue to be covered through Medicaid, but the parents would be eligible on our commercial side. Again, if there's no BHP, that family with an income of 180% of FPL, which is about $48,000 a year, would pay more than $2,500 a year in premiums. And the cost of care would mean they would not be able to get care because there'll be a deductible of $300 for the family. $25 per visit for primary care, $40 for specialists, and the co-insurance on a hospital stay is 20%, and that assumes cost-sharing reductions. Essentially, commercial coverage is not the best option for this population. The ACA benefit structure in the BHP is very robust. It's all the same benefits as on our commercial side. I do want to note, however, that the ACA coverage for BHP prohibits payment for pregnant people who qualify for Medicaid. So coverage to the payment to the MCO will continue through Medicaid for pregnant people who are eligible for Medicaid, I should clarify. Other examples of services not covered on the BHP ACA coverage design include adult dental, adult vision, and non-emergency transportation. Behavioral health is covered differently than under Medicaid. And I just want to again say all the other ACA benefits apply: hospitalization, lab work, preventive care, specialist, primary care, et cetera. Excellent coverage. And I'll finish by just saying a couple of things about our budget. Our budget, proposed budget for FY26 is almost the same as FY25. We use a very robust stakeholder engagement process to develop it. And our assessment for FY26 is projected to be at the same level as for FY25 at 0.80%. I'm over time. I'm happy to take any questions you may have.
Okay, thank you so much. Director Turnage, since I think there's probably some overlap, why don't you go ahead and do the testimony for healthcare finance? Then I'll ask the overlapping questions, and then we'll excuse Ms. Kaufman, and then we can continue on the rest of the stuff about healthcare finance, if that's cool with you.
You want me to do the full 100 pages? No,
We always do this, but we have a bet on how many SAT words you're going to do today. So let's see what the under is where you go. Help me out. You don't know what my over under is, but I need you to lean in.
Okay. Thank you, Chairperson Henderson. I am pleased to be here to present the mayor's proposed budget for DHCF for fiscal year 26. On slide 3, you can see joining me today are my outstanding team. I have my experienced executive management team with me and the agency's exceptional fiscal officer. We have very high-performing administrators and some of our key managers. And of course, my chief of staff who manages the flow of the work in the agency and the executive suite and keeps everybody on track is here as well. This budget season, as you know, occasioned several significant developments that forced the mayor to reconsider the protection proffered by the district's expansive healthcare social safety net due to double-digit growth in DHCF's local fund for both the Medicaid and the Alliance programs, and just opposed against the city's really sharp declines in its projected four-year revenue picture. We were forced to submit some cost-saving proposals that in some ways fundamentally depart from prior efforts to wrench savings from the Medicaid and the Alliance program. If you go to slide 4, it focuses on what my testimony will address. I'll talk a little bit about the fiscal environment in which we were forced to operate while dealing with countervailing growth trends for both Medicaid and the Alliance. I'll discuss the framework we use to slow the growth in Medicaid and Alliance, both of which are entitlement programs, and that creates special difficulties. I'll talk about the changes made to the Medicaid eligibility thresholds, its program benefits, and our provider rate policies, again, as a part of slowing the growth in the program. And then I'd like to discuss some changes to reform and reduce the financial footprint of the locally funded Alliance program. And finally, we'll talk a little bit about the status of the state-directed payment proposal for hospitals that is tied to an industry tax. If you go to slide 6, this is the slide that people have probably seen across the city by now, but it shows that the projected revenues for the remainder of the financial plan, 26 through 28, we're losing $1 billion, and that's due to a number of factors, not the least of which is the loss of federal employment for DC residents and the continued softening of the commercial office market. If you go to slide 7, why does this create challenges for DHCF? Well, this is an interesting slide that the blue bar shows you what we would have to spend locally if there were no changes in 26 to the Medicaid and Alliance programs compared to what we did in 25. The green bar next to it shows what we are projecting as the Medicaid and Alliance costs for the remainder of this year. So if you look over to the right, you'll see the city's revenue growth projection from fiscal year 25 to 26. It is rounded up to be a negative 1%. That's negative below the, that's negative, that's not a slowing of growth. That's a loss from your base funding level. And then you compare that to what the Medicaid and Alliance growth trends are. That's a 15% projected growth trend without some reductions that are reflected in the mayor's proposal. So and if you look at Medicaid alone, the unbudgeted amount going into this fiscal year before we had the news that there would be a reduction of $1 billion, the unbudgeted amount was $182 million, which is about total funds about $600 million that we would, if we took that total amount, that we would be removing from the healthcare system for Medicaid. Now, so we had to always, when you get these budget marks that you have to hit, and they're significant, as in the case of Medicaid, we have to have a framework in which we operate. If you go to slide 9, you know, if you think about Medicaid in DC, and you think about Medicaid all over the country, there are really 3 foundational pillars, is what we call them. One is eligibility. We have the highest eligibility levels in the country for most groups. And benefits, we have some of the most expansive benefits, if not the most in the country. And we do establish very fair provider reimbursement rates, exception made for dental up until this year. We dropped the ball on that, but we have corrected it. So you have to look at those 3 things. And when you do that, and we did that in a way and generated, next slide shows $332 million in local fund savings for Medicaid and Alliance. And the mayor returned $142 million of that $332 in investments. So that left us with a net savings amount of $191 million. The largest reductions were made in eligibility. 88% of the reductions came from eligibility. The remaining 12% were efficiencies, rate reductions, and some changes to services. If you go to slide 11, and you look at the numbers highlighted in red, it shows you what our approved budget was in 25, what we are proposing in 26. So you have a year-over-year variance of 8.6 million, which is almost flat growth on the local fund side. There is a significant jump in federal Medicaid payments, about $500 million, but that's a function primarily of the ACR hospital enhanced payments, supplemental payments that we'll make if CMS approves the proposal. We're still waiting to hear from them on 25. So what goals did we pursue in making eligibility changes? We knew it would be very, very significant and somewhat controversial because of the history of the district's fidelity to the notion that everybody should be insured. So we decided to do 3 things. First, we wanted to focus on optional populations. We really have no choice in that matter, because if they're mandatory as a part of our agreement with the federal government, we cannot eliminate persons who have mandatory coverage. So we focused on the optional groups. We then focused on those beneficiaries who were at the highest end of the eligibility thresholds. And then we thought about, after talking internally, we thought about the qualified health plan and whether, the commercial qualified health plans on the exchange and whether that would make a difference. We then called Mila and she said, we can do a basic health plan. And I said, what's that? And she told me, and we said, that sounds perfect. So we focused reductions on persons who have those 2 options, the exchange and the basic health plan. If you go to slide 14, this sort of exemplifies this notion of mandatory versus optional persons in Medicaid. The blue bars represent those that are optional. The green are mandatory. And the bars that are blue but with the slanted bars in between, those are the groups that we focused on for hidden eligibility savings. For childless adults, we looked at people who were at 134 to 210% of federal poverty. For parent caretaker relatives, we looked at folks who were at 134 to 216% of poverty. Those two groups, if you go to the next slide, those two groups represent 25,575 total beneficiaries. Now this is and I believe this is a point in time estimate. So these numbers will move around a little bit as time changes, because eligibility is a dynamic process. People move in and off the program. People move across income levels based on changes in jobs. So at the time that we did this analysis, we identified 25,575 people who would be impacted, and it would save, we estimated, about $42.8 million. Mila has discussed the basic health plan as an option and the qualified health plan, so I won't belabor the points that she has made. I will say that one of the things that our actuary dropped in our lab on slide 17, Mila disagrees with this, that we believe the populations that are going to the exchange are not as high risk or not as risky with respect to their healthcare profile as those who are staying with Medicaid. Mila says she doesn't believe it. Her actuary will take a look at it, as ours have, and it doesn't really matter. It just means if she's right, then it'll be a little more costly. If I'm right, then we may even save some money. So if you go to the next slide, 18, it shows you what the impact of the changes are looking out across 2026. At the end of 2026, we'll have, without these changes, we would have had about 261,000 people in the program. With these changes, that number drops to 235,000, and it is a number that flows through the financial plan in terms of the savings. Now I want to turn to Medicaid program efficiencies. We did a number of things to try to produce savings in that. We had some small savings by, we believe, reducing waste in the durable medical waste program, medical equipment program. We made some changes to, we incorporated in the budget our plans to make some changes to long-term care, where we won't automatically fund the highest level of PCA hours. We'll look at other strategies that may be ways to reduce their cost and improve the quality of care. Angelique and Melissa and her team can talk a lot about the thinking behind that. We also, to put it as pointed as I can, we took $5 million from the health plans up front, but we didn't do this capriciously. We basically told them that, for years we look at whether or not they are successful in reducing low acuity, the use of the emergency room by persons who have low acuity, whether or not they are reducing the rate at which people return to a hospital after 30 days after the initial admission, and we're looking at whether or not they are successful in reducing avoidable hospital admissions. In the past, we've put a certain percentage of their cap rate, about 1 or 2%. We've set that aside, and if they are successful, they get it back. The performance on that system has been relatively uneven, and we've had some breaks in the years that we could execute it. So we decided that let's turn the heat up on the health plans a little bit by taking this money up front. So if they want to not have it impact their financial profile, then they have to produce these outcomes so they won't feel the $5 million reduction. We're also planning to maximize the drug rebate for these are for prescription drugs that are paid through providers other than a pharmacy. For example, outpatient hospitals. We think we can save about $9.1 million. We've been missing this in the past, and thankfully somebody caught it, and we are now planning to capture those rebates moving forward. And then on cost shifts, Medicare we're going to shift the end-stage renal disease cost to Medicare. That's a $5.1 million savings. And then on emergency transportation, we're going to include in the emergency program the cost of emergency transportation is about $3.3 billion. Provider rates on slide 22 got a lot of discussion. We've met with, I think, all the provider groups, and they mostly are not happy. And no one typically is happy when they have to take, a haircut based on financial circumstances that we can't avoid. But the good news first is dental. After 10 years, we've discovered that this issue should be addressed, and they're going to get almost $8 million in rate enhancements that basically cover over 125 dental codes. We now pay higher than Maryland and Virginia for this. We're also going to pay the DSP wage enhancement for our home health care operation, home health agencies. That is $21.11. I do know this is a one-time enhancement, and that has caused some concern among the agencies, worried that this will not repeat in future years. They asked us why couldn't we put language in the budget that suggested this could be a more than one-time enhancement. And I told them that if we did that, the CFO would give us a bill that we didn't have the money to pay at this point. So the total enhancements, $14.5 million. And so if you then look at what is considered the bad news by the providers, we are delaying the rebasing for the federally qualified health centers, and it'll save about $4.4 million. There's a small reduction to ICF for reduced rebasing. It is still, we will still include an increase in the nursing component for ICFs, but overall rebasing outside of that will be reduced, including inflation. The nursing facility quality of care adjustment. This is an incentive payment that we use to fund quality of care in nursing homes. We're going to use that money to basically pay for the 2025 rate increase. We still will look at their quality measures, and obviously there's an expectation that those measures will be achieved because we are paying a base rate that is sufficient. We just put this in as a incentive payment, and in hard times we had to make some adjustments. Hospitals, they face a reduction of $6.3 million, and it is on the outpatient and inpatient side. We're going to pause inflation for both the inpatient and outpatient rates and generate $6.3 million. This is separate and apart from the state-directed payments, which are designed to pay an average commercial rate. Now to the Alliance program, slide 24. I went back and when I started to put this slide together in the dark of evening, I went back to my budget presentation in 2011, and I looked at what we were doing with the Alliance in 2011. At that time, there were 28,000 adults in the program and children in the ICF in the ICP program. The cost was $51 million. So you're talking about $1,800 on a per beneficiary basis. Fast forward to 2026, we are projecting 37,024 adults, which is not unusual growth. It is about 2% annually, 30% over from 2011 to 26, which computes to a 2% annual growth. But the cost for the Alliance since 2011 has grown by almost 385%. Without the savings initiatives that we plan, the cost of the program would hit almost $250 million, producing a per beneficiary cost of over $6,671. those are substantial increases. Now, we were able to handle these increases during the very robust revenue growth years for the city. I think after 2012, when there was a downturn, the numbers began to increase. We were averaging about 6% growth and getting reforecast that gives us a surplus much larger than what we've seen this round of reforecast. So we could afford it. But when now we're looking at negative growth in 26 and a loss of $1 billion over the next for the rest of the financial plan, we just don't have the money. So what did we do? First thing we did was to make the decision to move the beneficiaries who are in Alliance, both children and adults, who get their care managed through managed care, and we pay a capitated payment rate. It typically is around over $500 per member per month for adults, as I recall. We said we're going to take them out of managed care and put them in our fee-for-service program, which means we don't pay a capitated payment rate, and we only pay when a person actually goes to get care. The benefits were changed, but they are the major benefits. There's pharmacy, primary care, all hospital-based care, and non-emergency transportation. We established a hard enrollment cap that will be effective on August 1. And the cap is set at a forecasted enrollment of 28,000, but it will be whatever is in the program at that time. Our forecasts are pretty good. April does a wonderful job, but we're not always prescient, so we sometimes the forecast is a little off. But whatever the enrollment is in August 25, that will be the cap. The way the cap will work is if you're in the program and you stay in, you will be fine in 26. But if you leave the program, you cannot get back in. And if you are a new entrant seeking eligibility, seeking membership in the Alliance program, you won't be able to get in as well. Those are hard and difficult choices, mandated obviously by the just tremendous loss of revenue. The federal government is going to look like it's going to put Medicaid on the 6-month recertification. We don't particularly like it, but we will certainly do it, and we're going to set the Alliance on a 6-month recertification as well, face-to-face every 6 months. And there's a 90-day grace period for anybody who loses coverage during the, the administrative wrangling that sort of surrounds recertifications. You'll have 90 days to show us that, we made a mistake or you made a mistake. Program eligibility is being reduced to 134% of federal poverty, effective October 1. One of the reasons we do this, it's not the only reason, but when Medicaid and Alliance, we try to always make sure those eligibility levels are equal, because if we don't, if we leave Alliance here and drop Medicaid here, the people who lose coverage in Medicaid will simply go over to the Alliance. And so then the savings you would have hoped for would have been lost. So we have both programs, the eligibility level is reduced to 134%, and children age out of coverage after their 21st birthday. I think my testimony said the 18th, but it is the 21st birthday. So what does this mean in terms of enrollment? If you go to slide 26, we were projecting 32.6 thousand members in Alliance and ICP. Before these changes, we are now projecting 28,000, which is, a reduction of 4,600 members. Now, last issue is the ACA. We are, as you know, the industry agreed to tax itself significantly, I might add, to generate higher payment rates to cover their burgeoning costs. We submitted the 25 proposal to CMS, and we have been since responding to their request for additional data back and forth. They have not, as yet, approved the 25 proposal. We believe they will. They have requested some data as late as this quarter that we have provided. In the meantime, we are, in the mayor's budget is the fiscal year 26 proposal and the supporting BCA language that is, it is self-executing based on whatever the amount of the provided, the rate enhancement the hospitals can agree on. So we are assuming approval, and we hope it will occur before, obviously, the next fiscal year, because then that would create a real problem if it doesn't. Once we get approval, we will recoup the dish payments we've made to Howard, because Howard was probably one of the only hospitals that remaining that would get dish, because there was such a huge delay in the ACR payments. We couldn't have them sitting there with no dish payments and no ACR, so we gave them a dish payment. We would recoup that. The state-directed payments to the MCOs would be itemized for each hospital. They will get it based on utilization, and the new provider tax will be collected. We hope that transpires. There's a lot of noise at the federal level around provider tax. There's huge antipathy in the House, and I don't know about the Senate, around this notion of using provider taxes to increase the federal share of the Medicaid program. So, Madam Chairwoman, this concludes my testimony for this budget hearing. As I stated at the outset, the challenging nature of the city's finances combined with the unsustainable cost growth in both the Medicaid and the Alliance programs really require budget savings actions that have no historical precedent in the district. However, the strategies that put forth were thoughtfully deliberated and crafted in a manner to minimize the loss of access to quality health care. Should the council pass the mayor's budget, hopefully unfettered, there's much work to be done to ensure its effective implementation. And we will, to that end, we will work with Mila Kaufman and her wonderful team of experts at the exchange to make the transition to other insurance programs as seamless as possible for those who will not have access to Medicaid coverage. My team and I are prepared to receive the committee's questions along, I assume, with Mila.
All right. Well, thank you both for walking through that and that information. I feel like of a lot of things in the mayor's proposed budget, this was one that we've gotten a lot of questions about. And so it's good to have it sort of in presentation form so that we can refer folks back to your testimonies. I'm going to start with some general questions about HBX, and then we will get to basic health questions, or excuse me, not basic health questions, basic health plan, and then we'll go from there. And of course, as my colleagues join, they join, and we'll certainly turn to them for any questions that they have. Okay, Director Kaufman, the Department of Insurance, Securities and Banking shared that the insurance carriers proposed 2026 health insurance rates, which showed increases across the board. And this was even before we know what's going to happen with the reconciliation bill and what's going to happen with tax credits, et cetera. We know that HBX advocated for lower rates and premiums in the district. Do you anticipate that these proposed rates will be finalized with no changes? And if so, how do we move forward?
Thank you for that. So every year, we testify advocating for the lowest possible premiums. The final decision maker is the insurance commissioner and her team, of course. But every year we have our external actuaries helping to look at the rates, figuring out whether there are any calculation issues or data is not supporting the proposed increases. And ultimately, based on that review and policy considerations, I testify every year before the insurance commissioner, and every year we either ask for no rate increases or much lower rate increases than proposed. And we have every intent to do that again this year.
Okay, but I guess from a timing perspective, let's say there is the expiration that occurs at the end of December for the tax credits. When you compound that against the carriers piece, I just want people to sort of be prepared, because I feel like in some cases they like will automatically assume that their increasing premiums is something that the local government did, as opposed to, no, you might have lost the tax credit and the insurance carriers wanted more. So I don't know, when will all of this be finalized timeline wise?
Typically, rates are finalized sometime in September.
Okay.
This year, it will be very challenging for us to communicate with all enrollees about the impact of the rate changes. About 75% on the individual side are full pay. So what they'll see is typical increases. However, the 25% who get lower premiums because of the enhanced premium tax credit, because of that health insurance tax credit I spoke about, their premiums will skyrocket because the impact of losing lower premiums when the APTC reverts back to traditional ACA level is going to be huge. It will dwarf any regular premium increases that we're seeing. We expect many people to lose their health coverage as a result if Congress does not extend enhanced premium tax credits.
Okay. Just underscores the need for folks to lean in terms of the Senate.
And I'm sorry, just 4 million, approximately 4 million people. Congressional Budget Office did some estimates if enhanced premium tax credit is not extended, and they expect approximately 4 million across the nation to lose coverage just from that piece alone.
Okay. Even with the proposed insurance carrier rate increases, my understanding is that HBX's assessment rate is remaining the same as FY25.
0.80% is our assessment rate.
Okay. And will this have any impact on your ability to do your functions as an organization?
No.
Okay. All right. That question. Let's turn to healthcare for childcare really quickly. So the pay equity fund has been included as one-time funding for the mayor's budget for FY26. We've been having these ongoing conversations as a body around one-time funding versus permanent funding. And I just want to be very clear, we had permanent funding in for the pay equity fund throughout the entire financial plan. The mayor took that money, so that's how you get back to one-time funding. How long is HBX able to sustain the healthcare for childcare program? The funding that you currently have now and the funding that's in the budget for FY26, will that get you through full plan year 2026?
So currently we have 12 million for FY25. There's another 12 million for 26. We expect that currently enrolled facilities, employers, as well as workers and their dependents will continue their coverage. If facilities grow, hire new people, those new workers will be able to come in, as well as any DC residents. The wait list we currently have is for new facilities enrolling. And right now we have one entity on the wait list with less than a handful of workers who are waiting. But we believe that the 12 million in the mayor's proposed budget is sufficient to continue enrollment in this program and maintain the enrollment levels.
Okay. How much additional funding is required to clear your wait list?
I'll have to check. Premiums are based on one's age. And so I need to check the age for I think there are maybe 3 or 4 people in the group on the wait list.
Okay.
And I also need to check their enrollment status in other programs. These are not DC residents, and so they may be in Medicaid coverage in Maryland or Virginia, as well as maybe in spousal coverage. So I need to check their coverage status plus their age, because premiums are based on age.
Okay, we'll follow up on that. All right, so let's check in on something we did a year ago or so, which is the fertility benefit that was added. How many people have used the fertility benefit, or I guess as a different way of, how many claims have you had on the fertility benefit since the rollout of that law effective January 1, 2025?
I have two data points. One is paid and validated claims for Q1, which is subject to the defrayal requirement under the federal law. So the total of paid and validated claims is $853,361. That includes 2,723 people. So those claims are for 2,723 people. The separate data point I have is claims that have been incurred but have not yet been paid or validated. That's almost 1.1 million for the first quarter. So our external actuaries are reviewing those incurred but not paid or validated claims. And I do not have an estimate of how many people are in that second bucket representing those claims.
Okay. This is way more than what we thought. We're only talking about Q1. Positive, yay, people are using the benefit. Yay, there was demand and also a lot. Now, Director Turnage, we didn't cover the full piece for Medicaid. We covered drugs. Well, not drugs in drugs, but like specific for this.
I'm saying,
Do you guys have any data in terms of?
I don't have any with me. I don't, did we run any numbers on that? Yeah.
Come on to the table. Introduce yourself for the record. Look at this, your data guru, ready to go.
Good morning, Melissa Bird, Medicaid Director, Senior Deputy Director at Healthcare Finance. In fiscal year 24, we had 26 beneficiaries utilizing or with infertility diagnosis and utilization of the fertility enhancing drugs. To date, in fiscal year 2025, we've had 9 individuals, and we would expect the same utilization for the remainder of the year.
Okay, you said 9 for fiscal year 25 to date.
That's correct.
Okay. Okay, so a lot going on here. So recognizing that the federal law requires the district to defray claims costs, we have a spending pressure already. Director Kaufman?
I'm sorry, I didn't hear the last part.
We already have a spending pressure.
Yes, our actuaries estimate that by the end of this calendar year, remember our defrayal obligation, local defrayal obligation is for this calendar year, because starting in January of 2026, this benefit is part of the essential health benefits benchmark and no longer requires defrayal. So our external actuaries estimate that we will see between $4 and $6 million in claims. That includes both individual and our small group side, $4 to $6 million in claims for calendar year 2025.
Okay. And just to be clear for the folks who might be listening in, this is for both individual and our shop, which includes businesses, could include Congress, all of these different things in terms of the exchange.
Correct. On our group side, we have district small businesses, nonprofits, as well as the congressional enrollees are on the group side.
Okay. All right. So we're gonna have to deal with our obligations for 2025. I'm a little bit over my time. We've been joined by Councilmember Zachary Parker from Ward 5, who's a member of this committee. Councilmember Parker, both Director Kaufman and Director Turnage, well, right now, Deputy Mayor Turnage is only answering questions as it relates to healthcare finance. We'll get to DMHHS later. And then, but if you have any questions for Director Kaufman, get those out of the way first, because she will be leaving first.
Got it.
Okay, all right. You have 10 minutes, go ahead.
Thank you, Chairperson Henderson. Director Kaufman, I will come to you first. The proposed budget makes a substantial cut in information technology services, it appears, in the amount of $14 million with $0 allocated in fiscal year 26. Are these funds used for maintenance of the HealthLink online services, or how can you speak to the decrease?
Thank you for that question. So last year I sat before you and I aired some concerns about the DIF system not showing our budget in an accurate, transparent way. I so much appreciate the work of the mayor's budget team in working with us to correct that. So what you see in the budget chapter are a bunch of corrections. IT used to be part of the AMP budget. Now it's been zeroed out for that. And you see a whole IT section in the budget chapter. So it's essentially a different way, we think a more transparent way to show you where our expenses are. So in the budget chapter charts, you should see the entire IT budget of, I think, over 14 million.
Got it. So essentially that is a correction.
One of the corrections,
the-
one of several, yes.
Is that the case also for the cut for marketplace innovation policy and operations?
Yes, so that, we used to lump everything together, both our individual side and our group coverage. And that makes it harder for the public and you to figure out what we actually do. That's why in our PowerPoints, we always gave you details. So you should be seeing two different divisions essentially. And their budgets are 2/3 and 1/3 or so. The group side is still larger than the individual side, but everything that you're seeing zeroed out, it's because now there's a better way to present that, what we actually do.
Got it. That makes sense. And I'm assuming the additions for partnerships and marketplace operations and health coverage and innovation is part of that shift.
Correct.
Got it.
Yeah, health coverage and innovation includes our individual marketplace as well as healthcare for childcare. And that's where the basic health program will sit as well.
Can you speak to the mayor's proposed change where the mayor's proposing to move people to this basic health program, and what are the implications to coverage and quality of service that we might anticipate?
Yes, thank you. So the mayor's team came to us earlier this year asking us for options. We at HBX worked closely with our board members, and we presented the mayor with an option to establish the basic health plan. Instead of putting district residents into our commercial coverage, we proposed the option of the basic health plan, and the mayor agreed with us that establishing a basic health plan here is a way to make sure that the affected individuals who will no longer be eligible for Medicaid will have affordable, high-quality coverage and care. And our goals, of course, are to ensure continuity of care and continuity of coverage. And so we've invited all of the MCOs currently participating in Medicaid to also participate in the basic health plan. We're still going through our estimates with our actuaries, but preliminarily, we're seeing that we can design a coverage option for these residents that have no premiums and no out-of-pocket. That compared to coming into DC HealthLink commercial side is you will have premiums and you will have out-of-pocket
So
costs.
what would you argue is the difference? That's great. It's great that they won't have a premium out-of-pocket expense, but I would imagine there is a difference from being covered with Medicaid.
That's correct. So the benefit structure, the benefit design is based on the Affordable Care Act commercial side. That is different than Medicaid. The biggest differences are there's no adult dental, no adult vision, and ACA commercial coverage does not cover non-emergency transportation. It covers emergency transportation, but does not cover
So
non-emergency.
big differences, adult dental, adult vision, non-emergency transportation. But also what I'm hearing you say is essentially whatever the marketplace generally covers, they would have access to. If the marketplace doesn't, or this provider doesn't, then these beneficiaries would not have access to that care.
I don't know what that is. All right, you'll have to say that. I'm sorry, we're having a sidebar conversation. Yeah. One other difference, I just want to make sure so
Yep.
I'm answering your complete, giving you a complete answer for your question. Behavioral health is also covered under ACA, but it's covered differently than Medicaid. And then one other important point, pregnant people who qualify for Medicaid will not be covered in the basic health plan. Federal law prohibits covering pregnant people who qualify for Medicaid, so they will remain covered under Medicaid. So those are the important facts to get out there. In terms of network, if I'm covered in Medicaid and I have a certain physician I see and I want to continue to see that person, right? We've invited all of the MCOs to participate in the basic health plan. That will help with continuity of care because the network is what the MCO has. And also with coverage, you can stay with your MCO.
And what has been the biggest point of feedback or pushback you've received from MCOs, if any?
We just started our meetings with the MCOs last week. We've had two different committees we've established. One is IT and one is a process committee. So far, we haven't had pushback. We've committed to each of the current MCOs to do what we can to eliminate all IT technical barriers and all regulatory barriers. We want to get them each through the finish line so they can participate in the basic health plan. And hence the two working groups where they're bringing their technical experts, we have ours. We're going to be building, our connections together and empowering them to participate. Ultimately, it is their decision. We cannot require them to participate in the basic health plan.
Okay, and one last question here. Are there caps or limits to long-term care, certain types of surgeries, things that one might expect to be provided by Medicaid with this new health plan?
Yeah, on the Affordable Care Act, commercial side, there is no long-term care. It's a commercial product. It's what all of us have. And so long-term care is not a benefit. Do you want to say anything about
So these are significant changes. I just think it's important for people to recognize that. It's not like, oh, we're moving people off of Medicaid and giving them a new shiny object. We're moving people off Medicare, still giving them access to care, but there are significant changes and limitations to that care. And I just think people should be clear-eyed about that.
ACA coverage is commercial, private coverage. It is different than Medicaid, but it's excellent coverage. When you're sick, it gets you the financial protection and, more importantly, access to care. And that's why it was such a huge celebration when the Affordable Care Act was enacted. It is real coverage. It is excellent coverage. It is different than Medicaid.
Yes. Okay. That is my time for this round. Turnage, I have some, Director Turner, Deputy Mayor Turnage, I have questions for you. Yeah, I'll catch you on the next round. Thank you.
Thank you, Councilmember Parker. Let's stick on basic health plan. First off, do we have to call it that?
No,
Okay.
that's the federal lingo. In fact,
It just sounds so
terrible.
basic.
Yeah, so we have some options for names. One of the areas we'll get our feedback on from our advisory council on this is naming. How do we name it so it becomes a recognized name brand?
Okay. And I mean, you know, in the marketplace in general, we talk about plans based on medals, right? Silver, bronze, gold, platinum, XYZ. I don't know if you can have a medal for this, but calling it basic feels like it's a lower product. And we want to try to change that a little bit.
We agree.
Now, my second question, and we've gotten this as well, Councilmember Parker and I hosted a meeting together in Ward 5 where we were talking to residents about this, is if the basic health plan is so good, why didn't we do it before? Now. Sure, Director Turnage.
There are a couple of reasons. One is not Medicaid, as Mila stated. It is excellent coverage, but it is not Medicaid. And so the other issue relates to the district's history of trying to be a full coverage state. If you, we have a Medicaid and Alliance program where you pay nothing, zero, for your health care. And if you suddenly move people to other options that require some payment, the concern would be that they would, however de minimis those payments are, that they would elect not to enroll, and they would be uninsured, and we would see our uninsured rates go up. So I think that the reality that there are some services, particularly long-term care, where you say you need a long-term care service and you're not yet eligible for Medicare or disability, but you need long-term care, you wouldn't be able to get it from a commercial product. And that's not just a basic health plan. That's your typical commercial product. And the other would be the concern that we would have some slippage in people who decided to enroll. And so, you know, the option was to make sure that we have, that we maximize the federal coverage on the Medicaid side. And, you know, the ability to do that once Obamacare was passed, really cost effective. I mean, you talking about childless adults who had no coverage prior to Obamacare. Now we have about 95,000 in the Medicaid program. They cost $1 billion, and we pay, you know, 10% of that.
Yeah.
So those factors were all at play.
I mean, which are very good goals. I mean, I love the fact that we have always been able, not always, but in the last few years, been able to boast that we have one of the highest percentages of folks who are covered in the district. But with that.
Yeah, we're the only state, I believe, that covers, that up to now, that covered adults over 33% of poverty for childless adults. Nobody else covered those. They pretty much sent them to the exchange. We elected not to do that.
Yeah. Okay, so you discussed in your testimony, there are some similar things. Vision is not covered, dental is not covered, non-emergency transport. What's the definition of non-emergency transport? Would that be like if, so right now under Medicaid with MCOs, they might cover transportation to and from a doctor's appointment?
Correct.
Okay.
Yep, you got a doctor's appointment or you just don't feel well, it's not, it doesn't rise to the level of calling an ambulance, you call Lyft or whatever service your managed care company uses, and they will take you to the doctor.
Okay, but sometimes we might have residents who call 911 to use EMS to be transported to the hospital, even though it was for a non-emergent
Yes.
reason. What would
Yes.
happen in those situations?
It's a good question I know we had a program that, where those calls were sort of filtered, and they asked the the person who was making the call a series of questions, and depending on the answer to those questions, they were, it was suggested that they, use something other than 911. I haven't looked at that program in a while. I need to check the status of it, but there was an attempt to make sure people weren't using 911 for the most of prosaic of reasons.
Okay. Mila?
And just on the commercial side, the way it works is usually it's a reasonable person standard. If a reasonable person believes they're having an emergency,
Okay.
then it's covered as an emergency, even when you get to the hospital and turns out you're not having a stroke or a heart attack, it's something else. If a reasonable person believes it's an emergency, that's the way it typically works on the commercial side.
Okay. If we wanted to add dental, how much is that?
Our estimates show it's about $17 per member per month, but we can get you more precise information on that.
Okay. Just trying to give my colleagues options here, a little price list, if you will. But vision is not anything on the exchange. Vision is a link to somebody else's website.
So under the ACA marketplaces, not just in DC, but ACA marketplaces can only have qualified health plans and qualified dental plans. That's why we have standalone dental offered, but that's why we also do not have traditional vision where we can actually do your enrollment for you. Folks who want vision back in 2013 or 2014, it's all murky now. We did work with VSP to offer a discounted vision plan to any resident who wants to buy it themselves directly. So if you go to DC Health Link, you can click on vision and you will be taken to VSP.
Okay. On another day, I'll give my soapbox about how I think this is so ridiculous that the federal government has decided that your eyes and your teeth are separate from the rest of your body in terms of health insurance coverage. Because like, what lobbyist was like, no, vision cannot be on the exchange because I want my brokerage fee? Like, this is a pain point. I think as we try to sell this to folks, especially if you're in that population of you're not yet 65, you could be ophthalmologist, you have to be with an optometrist. And, I don't know what those costs look like out of pocket, but if you have glaucoma, I imagine that it's significant. You mentioned that behavioral health is different. Can you say more about this?
We're still trying to figure it out. It's quite complicated how Medicaid covers behavioral health services.
I know, they tried to move it into the MCOs and they couldn't.
Very
Yes, it
very different from the commercial side.
Hidden is probably not the best term.
So we're just trying to figure out what the precise differences are in behavioral health.
Okay. Do we anticipate, though, that it will look, when we talk about differences, right? In last week, we had the hearing for Department of Behavioral Health. They're making some changes in terms of like how many units someone can use for, say, community health. Did I say that right? Community support hours, et cetera. Is that what that looks like here?
I can't comment. All I can say is on the ACA front, on the commercial front, there's a very robust mental health behavioral health, substance use disorder benefit structure. It's actually based on back in the 90s when we first had mental health parity, if you remember then, and it's much more robust now, but it is different. I believe that the major differences are with Medicaid is who is actually in the network that you can get services covered through.
Okay.
But we're doing a deeper dive on that. And once we have a better handle on the differences, I'd like to report back to you.
Okay. Director Byrd or Director Turnage, have you all run the numbers of this 25,000 that we are proposing to transition? How many of them are receiving behavioral health services currently?
We've looked initially at the number of individuals that have received or utilized any of what we call mental health rehab services. And let me think real quick off the top of my head. What was the percentage? Okay, April's pulling it. I can tell you the overwhelming amount of or highest utilized service was community support. And then we had a very small number of individuals using assertive community treatment. And I feel like the total was about, I'm just gonna wait for April to pull it up.
Okay, here she is. April, always magical with the numbers.
Thank you. Yes, we identified about just over 2,000 individuals with any mental health rehab service use for fiscal year 2024. And again, the overwhelming majority of that was through community support, which is consistent with our overall utilization on MHRS.
Okay. The other thing, and I'm over my time on this round, that I'd be interested in you all looking at is how many people may transition to the BHP who are currently in permanent supportive housing. Because that's another one where I don't know if income-wise it might line up. I think income-wise if
We've
you're
had initial conversations about the overlap with permanent supportive housing or our housing supportive services benefit.
yes,
They're mostly lower income individuals, but we can do that data match for you.
okay.
Meaning they wouldn't be impacted moving transition.
That's what I'm just trying to make sure that we're checking all of our T's and dotting our I's here. The same I would say, and I know I'm over, but let me just finish this point. In terms of long-term care, if there's somebody who is currently in a nursing home who is on Medicaid and is in this population, although they might not be, because I know to get covered for long-term care under Medicaid, you essentially have to divest a lot of assets in order to qualify financially. What I don't want us to do is for somebody who's currently in a nursing home or in a group facility or independent living to somehow get a notice and say, you now have to come up with a cost for you to be able to stay in this particular housing scenario because you no longer qualify for Medicaid. So that's like a special population of individuals. I don't know. I imagine we're not talking about thousands of people. If anything, we're talking about probably less than 100, but we should have some sort of grandfathering to allow for those individuals to stay with Medicaid if it is meaning you get to stay in your housing, which I think is super important. So if we could look at that, that would be good.
Okay, we'll look it up. I don't imagine it is a significant number, but it sounds like you're saying one is too many. So we'll look it up.
Okay, thank you. Councilmember Parker?
I fully support that, by the way. Director Kaufman, I did want to come back. When is the plan being rolled out? What is the engagement process around that?
So we established a broad stakeholder advisory council. They had their first meeting this past Monday. We established 2 carrier working groups. One is IT and one is process. And they each met last week. All 3, the advisory council and the 2 carrier work groups are scheduled to meet each week, once a week. Some of those groups may have to meet more frequently. So our process includes getting lots of feedback from experts. And our advisory council, I should mention, includes physicians and consumer advocates and experts, health plans, from all wards. So we're getting a lot of input. The federal law requires any state pursuing a basic health plan to submit what is called a blueprint. Our timeline for that is at the staff level, we have most of it drafted. Today, when the advisory council meets, we're going to share what we've drafted, get their feedback, then modify our draft blueprint as appropriate, and then post it for public feedback. We're required to have it posted publicly for 30 days. And then we will finalize and submit to the federal government. All along, we've started our discussions with the federal partners, asking them to help us with this initiative. Once we have more decision points and more concrete information to share, we will do a more intentional effort to educate the community with concrete information. Right now, I don't want to go out there and say, well, our goal is to have no premiums and no cost sharing. But a goal is different than reality. So I want to be able to say to them, we know there won't be any premiums and no cost sharing.
And is it standard that the federal government approves these adjustments?
Basic health plan is an option under the ACA for states. And the 3 states that have it, New York was the first, and now it's evolved into a little bit more than a basic health program. Minnesota and Oregon, they all went through a blueprint process. The blueprint has to be reviewed and approved by the federal government. And then whatever process exists within CMS is what we're going to use.
Understood. Okay, thank you. So it sounds like we're quickly moving towards the submission of that blueprint. Assuming it's granted, do you have a ballpark when the new plan would be rolled out? Meaning
on our
meaning people are now being transitioned to this new health plan.
Our goal is on IT front to have all of our IT ready by October 1 because we go into what is called code freeze in time for our open enrollment for our individual market and group customers. So we don't do any major IT work past October 1. So we have to have everything ready on our side by October 1.
Okay, and that's a great segue. Deputy Mayor, can you speak to what is the transition process for people that are on Medicaid that will be transitioning to this new health plan?
As it has it, Melissa will be heading up that process internally and will be the face of the external presentations on this. The first member does not have to transfer, I think, until January 1. So there's a significant amount of time between when Mila's shuts down her IT work and the date that we want a member to have access to allow us to roll out a significant engagement and outreach process.
And is that, are those additional months accounted for in the budget?
Yes, the budget was set up, the savings were based, I think they were triggered starting January 1.
Got it.
Yeah.
Okay, that is helpful. Did you want to add to that?
Just in terms of the transition. So when I say we have to be ready by October 1, that means the 25,000 or so transition population. Our approach with the transition is, and we've already started this with the technical people at DCAS, is to make it a seamless transition where we get essentially a data file, if you will, and we run those folks through our eligibility, updated eligibility to make sure they qualify based on their income for the basic health plan, to make it automated so the person, the enrollee, doesn't have to do anything. Because we will get all of the information, income information, residency, verifications, everything from the current DCAS system. And we will run everything through our eligibility, create automatically accounts for residents if they want to go online and do stuff or update their information. But none of that will be required for most currently enrolled. We're using, so here, when states transition from the federal marketplace to a state-based marketplace, there's like a bulk transfer of enrollees. And the reason why it works well is because the enrollee is not required to do anything in most cases unless there's a discrepancy in information. And that's the process we intend to use with this population. In fact, we've already started on testing the data files or developing the data files. And we will be getting the entire population by early September to run through our own eligibility system.
Got it. The budget notes that if there are delays with federal approval, the district will need to identify additional funding to cover the cost beyond December 31st. Are there plans in place if there's something that happens with federal approval?
Well, the plan is hopefully that to not have that happen. It's a, the fact that this is an option under federal law, and we'll be doing something fairly straightforward. We don't anticipate any changes even under the new administration. But obviously, if something goes awry, then we would have to huddle and.
So it sounds like we haven't quite mapped out a backup plan. We would.
Yeah, we didn't build a budget with the expectation that key elements of it would fail.
Understood.
So the expectation is that Mila will deliver its promise.
I would just say, depending on the federal government nowadays for anything, I think should have an asterisk by it. In normal times, we can expect things to happen as they should. I think we can all agree these are not normal times.
Right.
I'm going to keep it moving. The fiscal year 26 budget proposes a decrease of 1.3 million in intake and assessment for long-term care. Turnish, this is for you. Like, how will this impact people's long-term care assistance?
I'm sure, and I welcome our Senior Deputy Director, Angelique Martin, up here as well. We're in the midst of a rate study for home health services and redefining potentially how we reimburse for those rates. So right now it's discrete. If you get home health, you may have a PCA, you may have skilled nursing, you may have occupational therapy, et cetera. But we think it makes more sense to probably move towards something that's more of a bundled payment that can really meet the individual needs. So it might be varying levels of services. And we think through that, we might be able to achieve those efficiencies by really just making sure we're providing options for the exact care that's needed versus just assuming that PCA is what all folks need.
So what I'm hearing is this cut will most likely impact providers versus the care that a patient might receive.
Possibly.
I mean, when we say efficiencies.
Nuance of that. I mean, if it's in the provider line, sure, but I think it's really, at the end of the day, has the potential to give the providers more flexibility as well. But
Okay.
yes, I mean, it's not necessarily, you can't say it's for a one-for-one benefit cut or a one-for-one cut to providers on that. If we're changing the methodology and the expectation and the service array, you may have all your needs met as an individual with a different service array, and the provider could, depending on the individual, be receiving the payment that they're accustomed to for that. So I can't say it's one for one, but you would see areas where clearly what someone is receiving now, they could do so with a lower cost service array. And then that's where you would see that savings difference.
Councilmember Henderson, do you mind if I just ask my last question? And I'm over. There's a subtitle that requires Alliance applicants to complete face-to-face interviews to certify their eligibility. Beginning on March 1st, it also removes several forms of identification that are acceptable to prove residency, including voter registration cards, canceled checks, receipts for mortgage payments, non-expired DC automobile insurance, et cetera. What is the plan for applicants who may have difficulty conducting face-to-face interviews? It seems like we're taking a step back, going back to the days of long lines and people trying to get access here. And then a second one, what is the rationale behind removing the documents to prove DC residency?
This is always a difficult issue to discuss for a number of reasons. There is over the years, there has been, some evidence that we've collected at DHCF that would suggest that there are a small but significant number of people on Alliance who apply, get the benefit, and then leave the city. And as a result, we are paying cap rates to manage care for people who are not in the city. And so one of the things we wanted to do was to make sure that, people were here and getting the benefit. And the face-to-face recertification requires that. And the documents that didn't necessarily, weren't
Before we get to
dispositive.
that, do you have an estimate of how big of a problem is that you suspect that we are covering people outside of the city?
It is, the challenge has always been, see, on the Medicaid side, we do the same analysis to make sure people are, we do the same type of analysis to make sure people are in the city. But we have a Social Security number that we can use, and it's very efficient. We don't have that on Alliance, so we have to use other methods, and they're not as clean. But we've seen data that would probably suggest that, I've always said the estimate was around 5 to 10%. And that number obviously will vary. So the history of recertification was when Alliance was growing rapidly, then Mayor Gray put something in place with a 6-month face-to-face recertification that carried over for years. So we're bringing it back because we think it's an effective tool. The hope is that people wouldn't gather outside of the service centers before they open. And the hope is that the service centers will be able to efficiently accommodate those who come, to do the recertification. I hope we can do
I'm
that.
way over time, but if you could just speak to the documentation changes.
I'm trying to remember which documents we now require. Are you asking about the rationale for it?
It removes several forms of identification as acceptable, including voter registration cards, canceled checks, rent payments, one card, an unexpired DC home or renter's policy. Those things were acceptable. Now we're saying they're not acceptable. Beginning March 1st is my understanding.
No, that's not.
My understanding is that we were adding requirements.
added
I think
those.
before it was 1 or 2 and we added requirements, and we wanted to be clear that it cannot be just a one card or something like that.
So they
we
can
doubled
still
language.
share these documents. They just need to have.
Yeah, those documents you identified are documents that we would want to see, actually.
Mhm.
Got it,
What
got it,
we
got it.
wanted to get away from was the use of a one card or
Just DMV.
or just DMV or somebody attesting to the fact that
I
the
got it.
person lives in DC.
Understood. Okay, that's my confusion. Thank you for the additional time, and thank you for your testimony.
Councilmember Parker, just so you know, on this in particular, we had asked DHCF to run the numbers of the number of individuals who had no claim, 12 months,
Yeah.
24 months, 36 months, or no claim history whatsoever. And a claim is like, you didn't go to the hospital, you didn't get a prescription, you didn't go to a clinic. While that is, you could be just a terribly healthy individual. To not have a single claim for 3 years, one could suggest either you don't live here or you're super healthy. And for the Alliance population, no claim in 3 years, it was about 2%. No claim history was about 15%. Yeah. So, and they ran it for both Alliance as well as Medicaid. And then we had some conversations at Performance Oversight around the use of the DC1 card alone as your proof of residency because it's very easy to get a DC-1 card, and the one card is actually an Octo product that doesn't expire. So there were, oh, sorry, 5 years. So it was a little bit different, but this was one of the things that we talked about as just sort of tightening up. And on that front, just as a follow-up, we had this question actually in Ward 5. Is there a waiting period to obtain coverage under the basic health plan? Someone sort of raised the idea that what if people come to DC, like, do you have to establish residency in order to qualify for BHP here?
So our intent is to use the same rules that apply for the commercial side. And so currently, this is assuming no changes, legislative or regulatory. Currently, if you have a qualifying life event, like moving into the district, you can enroll in our commercial side. The same would be true for the basic health plan. Otherwise, it's enrollment during open enrollment period that you would have.
Okay. Director Kaufman, I have maybe 5 or 6 more questions, but I know you need to perhaps take a break. Do you want to do that now? Okay, all right, so we're gonna take like a 2-minute break really quickly, and then we'll pop back on. Thanks. Okay, we are back. All right. I just have a couple more questions that kind of overlap, and then we will switch out and just talk specifically about healthcare finance. All right, can we talk a little bit about pregnant individuals? Because I feel like this could get convoluted in some ways. So pregnant women are not eligible for coverage under the basic health program. But most of insurance companies don't find out that someone is pregnant until there is a claim submitted if you go to a doctor, et cetera. Now, we also know that in the district, we have a healthy number of individuals who never seek prenatal care. And when they give birth is the time that we find out that they're pregnant, or their insurance company finds out that they're pregnant. So how is this transition sort of piece going to work? My hope is that this could be an MCO toggle back and forth as opposed to someone switching plans altogether. Have you all kind of thought about some of this?
Yeah, we share your concern for pregnant people who are eligible for Medicaid. And we think there are 200 or 300 a year of residents who may fall into that category. We've already started our discussions with the MCOs and the other HMOs about our expectations for participating in the basic health plan. Essentially, we're going to build into our contract with these entities that it is the entity's responsibility to notify us immediately when they have a claim or have another reason to know, because any overpayments we make will be clawed back because the federal basic health plan does not pay for those premiums.
Okay.
And it is better for the resident to get the full array of services, prenatal and post delivery, as possible. We would like for, even though it's not the basic health plan making payments for the pregnant person, our ideal is for Medicaid to make those payments to the MCO so the pregnant person doesn't have to switch MCOs or get the care in some other way. That is our ideal, but all of those discussions, we still have to have those discussions and finalize that population.
Okay. Dr. Turnage or Director Bird, can you clarify? I can't keep all of the various plans straight on the Hill, but is the 1-year postpartum coverage under Medicaid still alive?
Yes.
Okay, so it won't be you gave birth and now we're going to switch you back. It is a year. You get to stay on the Medicaid coverage
Yes.
for now.
Yes.
Okay, all right. Okay, I understand that you all have been having some conversations with providers already.
Yes.
Yes, so you met with the FQHCs.
Yes.
Have you talked to hospitals?
Yes.
What about the behavioral health providers? I know you don't have all that information yet, but I just want to make sure that everybody is in the
Sure.
conversation wheelhouse here. Now, I appreciate on the transition part that you were talking with Councilmember Parker about sort of getting the data file and then transferring over, but you've invited Kaiser and Care First to participate. I don't know if Kaiser will do it because they're a closed network and they may not be interested, but I do think that Care First has some interest here. What if I am currently in Amera Health and I want to switch to Care First? Will I have that option?
For the basic health plan?
Yeah.
Yeah, sure.
So for the 25,000 transfer population, we're trying to keep things as stable as possible for that population. So whatever MCO they have now, unless they have a qualifying life event and then they can switch, we're trying to keep that stable through open enrollment of 26.
Okay.
Any new customers who come in, obviously they'll choose from everyone that decides to participate. But existing customers or existing enrollees, we'd like to keep stability for a year. Obviously, this is one of those questions that we'll be working through with the federal government to, to figure out if there's a policy position there. But right now, our intent is to keep folks mapped to the MCO they're covered in, and that's where the coverage will be for a year in the basic health plan. And, subject to change based on our discussions with the federal government.
Okay. One last question. So New York State had BHP. They also then elected to expand it to a population to cover up to 200% of FPL.
Greater.
Greater. Let's say our finances improve. Is the basic health plan a type of thing where we can add eligibility or take away, is it nimble enough that we can make shifts?
So the basic health program is predefined in federal law.
Okay.
If you want to enhance it or grow eligibility,
Yeah.
the option is to go for a 1332 waiver process with the federal government.
Okay.
And that's what New York did.
Okay. All right. We're not there yet because we're not there yet. Let's just get through the first approvals first. I want to ask Director Turnage, do you have any concern about delaying the rebasing for FQHCs while also going through this transition with basic health plan and Alliance?
Well, it is
Oh,
not.
you got to just turn your mic on.
It is not without challenges, but I think it's executable. Certainly, when you have this many moving pieces, you have to have a very talented team that is dedicated and that will work long hours to see that it get done. And I think we have all that. So worried would be strong. Concern would be strong. Focused is probably the best word. We are focused on getting this done. And we believe we can pull it off.
Okay. I have actually another question. Okay, so Director Turnage, you talked about in your testimony on the Medicaid side, efficiency reforms in terms of durable medical equipment. Is durable medical equipment covered under BHP?
Yes.
Okay. How are you all going to, I guess, strive for parity here? By that, I mean, let's say I'm on Medicaid and I have all of these restrictions in terms of durable medical equipment, but I'm on BHP and I don't know if those same restrictions exist. How do we sort of manage this?
Sure. Are you fine?
Go ahead.
Okay, I'm happy to start out and may invite our chief medical officer up. I think the efficiencies in the budgets, is it 300 something thousand in savings? So we're really looking at more of making sure that we are looking proactively at utilization and is it appropriate? The example we gave at our MCAC meeting last week is identifying that we're paying for a lotion, like $25 for the lotion. There are alternatives. It's the wrong price. We shouldn't be doing that. So that's one of those areas like our practice.
For a
I don't
lotion?
think- Yes, exactly. And so that's why like our practice won't be dissimilar to what private healthcare plans are doing in terms of looking through how the utilization, is their spending correct? Are their rates correct? Is there an alternative that still meets the needs? So I think that's more along the lines of what we're discussing here.
Okay. But while we're talking about durable medical equipment, my understanding is that you're proposing not covering that for Alliance altogether. Don't you feel like it, and also for the public who may not know what durable medical equipment is, yes, it's wheelchairs and crutches, but it's also glucose monitors and oxygen machines. Like, if we don't cover these types of things, would that not have us incur more costs on the back end because somebody's going to the emergency room because their insulin levels are low? I love when you guys phone a friend. You just introduce yourself for the record.
Good morning, Dr. Shemaine LaBird, Board Certified Internal Medicine and Lifestyle Medicine, and the Chief Medical Officer.
Great.
So thank you. So to your question regarding parity, it's very important. In respect to the Alliance, that's one of the concerns that we talked about. There are going to be things that people are going to need that we're going to have to provide. So we're going to be diligent about how we look at the durable medical equipment from an Alliance perspective.
Okay.
In terms of efficiencies, one of the other things that I want to emphasize is we're not taking anything away. There are, in utilization and with coding, there are times when there are some unspecified codes which may be used inappropriately, or even just quantities or volume. So an example, an estimate in looking at underpads or chucks. We have over 30 months spent or used 10 million underpads, and the cost for those 10 million was $3 million. And so trying to understand, whether or not someone is, has a whole pile in their, house and they don't need them anymore versus someone that actually needs them. So we want to make sure that when the coding is submitted, that it's done correctly, the limits are correct to ensure that everyone's getting what they need. So those are some of the examples in terms of efficiencies that we'll also be looking at. In terms of parity with BHP, being on the advisory council, I'll be there to help along with the other physicians to say, hey, this is important to include, we should consider this, and making sure that those that are being transitioned, that we make sure that they continue and are consistent with those equipments.
Okay. I mean, I obviously I'm nervous because, as Councilman Parker said, we gotta rely on a federal government that changes hourly. But where I feel strong is this coordinated relationship that you guys are establishing here. And as I told folks in the community who they raised concerns about the call center and who do I call if I need help? And I was like, we get the least amount of complaints about the HBX call center. Their folks are very strong. So when you're transitioning over there, you're getting great customer. You're not getting less in terms of customer service, which I think is important. And so however we make this as seamless as possible, I think that's going to be super important. I don't have any more specific questions about basic health plan. Director Kaufman, I want to give you an opportunity to say anything that I didn't ask you, and then we'll switch over to some more meaty stuff on healthcare finance.
Thank you so much. I just want to clarify, we've been joined at the hip since 2013 when we built the ACA and online health insurance marketplace system together. And right now our two systems talk to each other. So it is no wrong door, no matter if people come to DC HealthLink or to District Direct, they can get into the right coverage. And we continue, obviously, that close relationship. I just didn't want it to seem like we've just started the close relationship, especially on the program side and the IT side. And then just to, if I didn't say it earlier, I wanted to make this point. The amount of federal dollars will determine what the basic health plan can do for residents. Our goal, again, is no premiums and no out-of-pocket cost sharing for medical care. If there's room to also pay for adult dental, adult vision, and other things, all of those obviously, or I shouldn't say obviously, but I should say definitely will be considered, and we will use our advisory council. But because adult dental does have high usage, it's a benefit that is very well needed and liked. That is absolutely top of our list, should there be enough funding. But again, we'll be seeking input from our advisory council to make those kinds of decisions. And all of that is based on the amount of federal funding that will be available. And I'll just close by saying how much I appreciate my own team. They have been working day and night to get a head start on this, and failure is never an option, especially to make sure that this population has continuity of coverage, continuity of care. We appreciate your strong partnership, and of course, the strong partnership we've always had with DHCF and DISB, and we will get this done for the district. And again, thank you to the mayor for entrusting us for going with our recommendation to move this program forward.
Great, awesome. Well, thank you so much for being here. So there are a couple of follow-ups, obviously, around behavioral health and otherwise. The other thing that we kind of need to know is that if you need emergency legislation to authorize you to submit or create, forget what the BSA subtitle says, but nonetheless, if you can't wait until, well, it's got to go for congressional review and all of these different things. If you can't wait that long, we need to know within the next week and a half or so that we can go ahead and move that on your behalf in July.
Thank you.
Great. All right. Let's continue conversation on Alliance. We're going to switch out. So the HBX folks are excused. Director Turnage, one thing that has come up in terms of the Alliance piece is behavioral health as well. We had our hearing with Department of Behavioral Health last week, and we discussed, we have a couple of providers for whom they would be hit pretty hard, just in general, by the transitions in terms of Alliance. Are there anticipated changes as it pertains to behavioral health for the Alliance population? Or if you just use your mic, just to clarify, right? Like, I understand we're making changes in terms of eligibility. Are we making changes in terms of behavioral health utilization for Alliance as well?
Did we change it? Yeah, go ahead.
So behavioral health services are not part of the Alliance program today. They are provided, through locally funded services through the Department of Behavioral Health. And they, my understanding is they are included for FY26 as well for DBH. Because behavioral health it's not technically part of the Alliance program today. Like we don't reimburse for those services through our managed care plans.
Okay, so, all right, we might have to come over this offline because I feel like we have to have a alignment amongst our agencies about what happens going forward in terms of the transition. So apologies on my part because I think there's a little bit of confusion here, but let's follow up on that a little bit. As we sort of, I will say this and then we're going to leave Alliance alone.
Okay.
I think we need to have more conversation about what happens if this transition needs to happen faster than what you have outlined in the budget.
I see. Yeah, I don't disagree with that.
And, plan B, plan C, plan D, whatever. I just know that I've got some providers in particular who are very concerned about the financial health of their organizations and their clinics being able to go forward. Especially since I think the penalty in reconciliation is going to stick in the Senate side.
Oh, well, that's a problem.
I don't know what the effective date is going to be, but I know it's going to be sooner than what we have outlined in the financial plan. And so we just need to be thinking about what does that transition look like so the bottom doesn't fall out of our public health system and our ERs are not now becoming even more so urgent care clinics for certain individuals seeking care.
We've had some internal thoughts about that issue and others, not as as something to mitigate the impact of the DHCF's proposed budget, but certainly something that we could pivot to as a proposal if the if Armageddon comes for the Alliance program.
Okay. All right, let's switch to DCAS. In the pre-hearing responses, Healthcare Finance indicated a 5.7 million in DCAS funding was shifted from reoccurring to one-time. And that will result in about $545,000 in savings. What software updates are we cutting or pausing due to this change?
So Tamika, you can come up with that. But I will start off to say.
Oh, Angela, you gotta just move it.
Oh.
Lean into the mic.
So I do want to start off by saying that the variance between the contract and the equipment that were cut for 25 is really, it's not that we're getting rid of equipment, it's that the costs were less expensive than we originally intended.
Okay.
And Tamika, did you want to get more detailed?
I think we're good.
Okay, yeah.
All right.
So we were able to maintain the software and equipment that we have, just at a lower cost.
Okay. The operations and maintenance contract for FY '26 appears to have been reduced to around 13.8 million. Is this with D2 Sol or another vendor?
Hi,
Hello.
Tamika DeWitt. The O&M contract is with D2 Sol.
Okay. So what services are we discontinuing or pausing due to the reduction? Because this is for FY '26, so we haven't started it yet.
Yes, so based on the information, the question I received, we did not cut any cost. We transferred funds. So we had previously staff who were under DCAS just as our regular staff. And then when we transitioned to D2 Sol, that funding also shifted with the vendor. So we reallocated our budget lines.
Okay. All right. Now, so here's my question/concern as we're sort of making some of these reductions on DCAS is because our friends on the other end of Pennsylvania Avenue might be instituting this little, what do they call it, community engagement that is going to require people to have to engage with the district direct system far more than they have to do now.
Mm-hmm.
Are there any updates that we would have to make in order to receive documentation, uploads, et cetera? Or is our current system already designed for that? And this is just a system load issue that we're gonna have to manage?
So no, currently right now, we can take uploads, we can, the traffic that is coming to District Direct, we can maintain. We can also increase the volume. That should not be an issue, but if we do foresee that, or we do project that to happen, we can check our loads, but I don't think that that's gonna be an issue.
Okay, so right now, obviously, well, not obviously, someone who is currently enrolled on the federal TANF program has to upload information ever so often.
Mhm.
Local TANF, we are freewheeling.
Mhm.
There is changes proposed in the budget to change that for the local program as well. People haven't had to submit this before for Medicaid. So this is a new thing for a new population of individuals. And frankly, when I look at who did it, Georgia, who's on the struggle bus of this, particularly for individuals of a certain age where it is not a pay stub, but rather I have to submit, I don't know, volunteer hours or something to that effect.
Mhm.
Is DCAS designed such that you don't have to make significant changes for the Medicaid population to be able to upload information, which is different than what they would be uploading in some cases for TANF?
Yeah, so I'll just answer that. It is a part of our standard case management with DCAS that you have the option to upload documents. So we do have that. Now with TANF, there's particularly two systems that DHS uses, right? So DCAS, just standard documentation that for eligibility, they would upload it to DCAS. But if it's more specific to their work requirements or things like that, they also have a separate system that I'm not sure yet. We haven't had those discussions if they will go through that native system or if they would use DCAS. But again, DCAS is equipped to take any documentation through either while you're in intake or even as a part of your regular maintenance of your case, that you could upload documentation at any time.
Okay, but you haven't had conversations with DHS about how to, if this goes through on the work requirement side for a new population of individuals, how you all, or how they, or you, I don't know, who
It's
is,
preliminary right now because
Okay.
we just don't have full guidance on it, and
Okay.
there's no decisions that have been made. So we've had high level discussions, but to get in the weeds in operations, we have not done that yet.
okay. This is something I had, when the House moved up the timeline to 2026, I was like,
Yes, we
they
have had those
they have
discussions.
not had conversations with anybody in a state, because what it would take for folks to turn around a system, if you actually want it to work,
Yes.
if you want folks to lose coverage, sure.
Agreed. We actually have a meeting where we'll be in person together this week on Wednesday.
Okay.
And that will be a part of our discussions moving forward as to all of the changes that are coming down or projected to come down. We will have discussion with the leadership, DHS, also our internal leadership, as well as HBX will be present.
And I would just add to that, I mean, if the reconciliation goes through as planned, obviously the district won't be on its own in this. We'll be connecting with states that have already implemented, Arkansas and Georgia. Georgia's just recently made changes to how frequently they require the attestation. So
They only do it annually.
Yes, now they do it annually, and it's an attestation. So I think it will be a lot of collaboration across states through the National Association for Medicaid Directors. They have several affinity groups, eligibility, work requirements, and so forth. So it really pulls together everyone, including our federal partners, in how to do this. So I agree with you that the timeline that was changed to next year is very aggressive and it's very challenging given what the kind of requirements we're looking at for community engagement.
We discussed during performance oversight that healthcare finance was working on a tool with DHS to simplify tracking the beneficiary's personal reference number. What's the status of this?
So we've we have a pilot that's going right now. Code for America actually helped and sponsored that. So we had our pilot group completed. We had great success with it. And now we are looking to see how we could roll that out across the service centers.
Okay. It's June 9th. What's the status of working with OSSI, the Office of State Superintendent of Education, and DHS to increase the Sunbucks participation for this summer?
I will have to get back to you on that.
Okay. You know what Sunbucks are?
Yes.
Okay, great. All right.
Yes.
We'll follow up on that.
We have that, but yeah.
Okay. It's an increased participation. It's not a program that you own.
Where I need to get back with
Yeah,
you
yeah,
on.
yeah. It's a different type of question. Okay. Now, okay. This is a follow-up from, I went to the Department of Human Services hearing last week,
Mhm.
and I asked about the SNAP error rate. And DHS opted for the corrective action plan after we had that back and forth with USDA, which directed about $2 million for DCAS. Per DHS is that they're going to be investing this $2.2 million back into DCAS for innovative upgrades.
Okay. So I think that I just want to correct that. It is their SNAP reinvestment for technology, but it's not synonymous with DCAS, right? I believe they said technology. They have their own OIS department in which they invest their own like case management type of technologies. And so what they were talking about was their automation for their robotic processing automation, RPAs. That is not through DCAS. That funding is not given to DCAS at all. It is separate and apart.
So they have a different contract for IT?
They have their own internal contracts. They have their own internal department that for their IT services. And so they do that via their own, remember they have like DIMS, they have Current, they have other products that they maintain and manage at DHS exclusively without, decision-making or autonomy from DCAS, input from DCAS.
Okay. So what, if any, I guess, Director Turnage, this could be, well, I don't know if this is necessarily healthcare finance or if this is DMHHS, but you're here and you're both people. What support, if any, has DHS asked you all around the SNAP error rate issue? Because when I asked Interim Director Pierre about this last week, I said, all right, the SNAP rate, she reports, has not significantly changed. There's a problem for me because if this reconciliation, well, it's this problem for all of us, because if this reconciliation bill goes up, this is like a $79 million problem that we have. We all have. And so I said, is the error rate, is it a system issue? Is it a human issue? And she couldn't really give me an answer. So my hope is that you all have been working on this over the past year to sort of diagnose how our rate is so high, like much higher than lots of other jurisdictions who have more beneficiaries, and what are we doing to get that number down?
Tamika can give you the details, but this is my understanding. The system is programmed to do what the policy requires. The caseworkers are very used to the old system. And so their interactions with the new system are not always as efficient.
But the system isn't really new
Well,
we're not talking about less than a year, 6 months, and right?
well,
We've had this for
a while. But, so I think, am I saying there are no system revisions that could be made? I'm not saying that, and Tamika could address that more accurately, but I do think this is more a human error problem than it is a systems problem.
Yes. So to piggyback what he's saying, the top 3 contributors to the error rate are due to wages and salaries, household comp, and shelter expenses.
wait.
Oh, sorry.
Wages and salaries.
Household composition and shelter expenses. It is the lack of adding this information or delay in adding this information to the system. It is not an issue of processing. And this is based on joint reports that we get from the quality assurance team over at DHS. So what I will say is we support DHS and we provide solutions to how we can make it more efficient. But again, we don't have autonomy to just go ahead and add functions to the system that DHS does not agree on. And so what we find is that this is a human issue, and that we just need to add the information to the system when it is available. And that's where we are working together with the quality assurance team, with DHS and their particular teams, as well as DCAS, to figure out if there's a way to support the workers more through training, is particularly where we are. There's no system intervention that can do this. We have 2 years ago, when this was brought up, we worked on all of the system issues that was a direct result of DCAS. We worked on those, we've implemented them, and now we're working and supporting the human side of it. And our contribution will be about training for that.
Okay. We're gonna come back to this on the DMHHS when you have that hat on, because as the head of the cluster, I are you concerned? And then what is the action plan, especially since DHS is going through a leadership transition, or is in a leadership transition rather, right, with an interim director. But if the top 3 problems is literally delay in inputting information, wage and salary, household compensation, household composition, and shelter expenses, this like harkens me back to that hearing that we had with Director Zeilinger, where we were talking about how many inputs the DHS team was doing in a day, which was woeful. but that was when they were home. And so now they're back, but we got to figure this out because that's we went back and forth on give SNAP a raise. You don't have to give SNAP a raise, just in a way that is not actually going to benefit anybody, but it's just going to be a punishment for the district altogether. $79 million hit we would take if we continue with this error rate that we have under the new piece. So we'll come back to that. This is helpful information, though. Let's move on to provider payments and credentialing. So we talked a little bit about the delay in the rebasing for FQHC's intermediate care facilities and behavioral health facilities. You guys have provider meetings with all of these various groups to discuss. Are there any unintended consequences that we might experience as a result of not moving on these payment increases, i.e. providers who are like, you know what, we're good?
For which provider group are we speaking?
Behavioral health?
It's it's a very small downward adjustment. So I can't imagine that we would have providers throwing up their hands and say, okay, I'm done, because their share of $224,000 was too much for them to bear. I'm less worried about that than I am other issues that are sort of endemic to some of the operational problems that some of the community providers have. That's much more concerning to me than the impact of these reductions.
Okay. So I met with the Primary Care Association, and you've met with the Primary Care Association. Obviously, for FQHCs, you say like they haven't had a rate increase since 2024. You add in inflation, just to buy supplies, materials, et cetera, then whatever COLA increases that they might have provided to their doctors, nurses, and staff. This is a bit of a hit here. But I'm sure you thought about this, discussed this, those kinds of things. We were happy to see the increase, the $8 million for dental.
Yep.
We talked about dental a lot, so I'm very glad about that. And the dentists are grateful that their concerns were heard and addressed in this. What's the effective date of the increase?
Our intent is to increase rates when we update the physician rates, which normally happen at the beginning of the calendar year.
So January 1.
Yes, we've also included it on the MCO side as well for, because one of the main issues with dentists is that they weren't getting the fee-for-service rate on the MCO side.
Right.
So that's also included in the MCO rates for FY26 as well.
Okay, great. Now, one group we haven't talked about yet, although we heard from them, is our pharmacists.
Yes.
The independent pharmacists, there were a group of them that testified at the performance oversight hearing about their reimbursement rates not being sufficient to cover their purchase of some of the drugs that are come up. Particularly those east of the river where they don't have Walgreens and CVS, right? These independent pharmacists are how individuals are getting their blood pressure medication, et cetera. What do we say to them?
I think they have a very legitimate concern. And I think it's mostly their payments that they get from the MCOs don't cover their costs, as I understand it.
Right.
We have engaged with a representative from the Pharmacy Association, and we will, much in the same way we did dental, we'll take a very, very hard look at this and, if necessary, lean on the health plans to fix. I mean, you can't have a situation where you're being reimbursed below cost for drugs. It just doesn't. You won't stay in business. It's not like some other areas of Medicaid. So that's something we are aware of, and we will have more conversations with the leadership for the Pharmacy Association, and we will have conversations with both with our MCO plans and our actuary to think about what options we have to address this.
Okay, that's good to hear. In your testimony, you referenced the nursing facility quality of care adjustment, using incentive payment funding to assist with the increase from FY '25, and that the quality incentive payments have been left on the table over the last 2 years. What quality metrics were you all looking at?
This was part of Angelique's magic. She can lay out the thinking here and what metrics we're focused on.
So currently, our long-term care department relies on the standard nursing home quality measures nationwide that are required. I can't think the acronym off the top of my head.
Okay.
But we utilize that and we look at it annually. Nursing homes have the ability to report the information. We've had some opt out of submitting the information to get the incentive award. And so over the course of the 2 years.
Like, is that reflective of it being, the standard being too high, or them back office just not having the capability to submit?
I can't answer that. We can follow up and find out their reasoning for not doing so. I know that our long-term care team has really worked with nursing homes. Even though we have taken away the incentive payment, the requirement is still there. Our quality oversight, we're increasing to make sure that we still want them to meet, the expectation is to still meet the standard. We still want our nursing homes to have the required number of stars. But on the financial side, that's a total of $8 million that we were able to invest, because the 2.4 is just the local share.
Okay.
And it was $8 million that we were able to invest in their rates. In 2025, we gave them a 13% increase to address their workforce issues with nursing. And so they did increase their tax by 0.5%, but raising the tax to 6% did not cover that 13% increase on its own. And so we believe that that investment helps us maintain their rates. We didn't have to cut their rates. We didn't have to push back their rebasing. We could reinvest that money within the nursing homes. And it still will address quality because it addresses workforce, the skilled workforce.
Okay. All right. We discussed at performance oversight the possibility of centralizing the provider credentialing through healthcare finance rather than having each MCO do the credentialing process themselves, as other states have already done. Do you guys have a cost estimate of how much it would cost to centralize credentialing?
We are in process of working through that and getting a cost estimate. I've got an initial decision memo from my staff. I had follow-up questions, so that's something we can come back to you on.
Okay. All right. So that is not ready for prime time.
That's correct.
Okay. All right. So I'm glad that the mayor's budget keeps the increased rate for direct support professionals for FY '26. Obviously concerned that we phase this out for the rest of the financial plan. We have a lot of phase outs in other programs in the financial plan where things that had been there is now one time. But I've tried to sort of quell the concern from some of those providers that this is a retreat from the policy as opposed to we needed to balance the out years. So I wanted to give you an opportunity to speak to some of the rationale there.
Sure. I don't, this is obviously a function of the city not having the resources based on the projected revenues for the next 4 years. Things that we have funded and would like to continue funding, some of those things got chopped because of the $1 billion decline in revenue. I didn't detect in my discussions with the city administrator, the budget director, and the mayor that we were taking on permanent policy shifts, but more reflecting the reality of our financial situation. Now, if that financial situation lingers, then what seems temporary could become, could seem permanent. Because the bottom line is you can't execute this service if you don't have the money, so.
Yeah.
But I didn't detect any discussions about, well, this is something we need to end anyway, so this is a good thing.
Okay. In terms of managed care oversight, you said in your testimony, you referenced savings due to program efficiencies and service reductions totaling about 24.3 million, one of which is a permanent 5 million withhold from the MCOs. I have sort of a multi-part question. So one, does HSCSN fit in this?
No, this is not something that, they're not a part of this particular program.
Okay. Now you described some of the targeted efficiency levels around, right? Like how often someone is going back to the emergency room
After how often they go back to the hospital after an inpatient admission within 30 days.
right.
Yeah.
How are you all sort of, I guess, being more nuanced about that depending on someone's particular disease and or condition? So
Well-
for instance, like sickle cell, which obviously if it's not managed appropriately, you're going to have somebody who's going back to the hospital perhaps multiple times.
Right.
Yeah.
Well, there's no punishment to the beneficiary. The emphasis is on the health plan. Are they going back to the hospital for a readmission for something that reflects a lack of attention in their discharge, in the execution of their discharge planning? And if so, you are partly responsible for that because it's one of the reasons we pay you. Are they going to the emergency room for headaches and nosebleeds and I just don't feel well syndromes because you don't have an effective care on case management program in place? And are they going to the hospital for legitimate issues that should have been treated on through primary care because you're not communicating with your beneficiaries? So those are the kind of things that we're focused on. And when we've taken their withhold, when we've held, one was 2%, then I think it went to 1%, but we saw some progress in them being able to lower the incidence of those problems to the point that I think at least one or two of them were able to recapture their entire withhold, or certainly a large portion of it. So we know this can be done.
Okay.
Now, they will say it's hard, but my response, if it were easy, we would do it ourselves. But that's why we pay you a lot of money. They get a lot of money from us.
Yeah. Okay. In that, because you said these types of policy changes does not impact HSCSN, what does oversight from healthcare finance look like for HSCSN? Where often here, I get complaints. Even, I was at a community meeting a couple of weeks ago and they said a parent had gotten a notice from HSCSN about some policy change that was taking place like July 1 effective, which I had said, well, that's not a policy change that has come from us. And I imagine that it hasn't come from healthcare finance, but can you speak to a little bit about how you all work with that particular plan? Especially when we're talking about the types of beneficiaries that they have. Obviously it's all children, but you're dealing with their families who constant complaints about customer service, sharing information, changes in policy that take place without much notice, those kinds of things.
Well, let me say, the first thing I emphasize when I deal with Melissa and Lisa on complaints that I get, and I get a lot of complaints as well from parents about HSCSN, I said we have to factor in the fact that they have some of the sickest kids in the city.
Yeah.
And so if there are things that we're doing that we know make sense, but it's not meeting the need of the parents and their kids, then we need to change. I think we have a pretty robust Oversight program. I think we have a program that will hold health plans accountable to the max. You know, we had a history of terminating some health plans over the course of my 14 years here. So I just would need to know more specifics about what the issues are. And they normally call me. I have, parents would call me on a regular basis, and I am very quick to suggest to Lisa and Melissa that, well, we need to reverse this. So I'm less concerned about the oversight, but I do recognize that this is a population that is extraordinarily frail. And if there are things that we're doing that need to be adjusted because of that, then we should just do it.
Okay, we could follow up with you on that. I will just say that, for some of the stories, and you get these calls too, right? A parent shouldn't have to have like a full-time job and trying to manage insurance,
No, you're right.
right? Having to provide documentation 3 or 4 times, having to make phone calls 3 or 4 times in a week just to get a response, just to get the prior authorization approvals, X, Y, or Z. So this has been going on for some time. I know that I think at least since I've been on the council, HSCSN has had some leadership changes,
Yeah.
but the complaints are still consistent.
Yeah.
And so, I don't know what that looks like.
Well, we have a procurement coming up. That's the first thing.
Okay.
I think that contract ends in next fall. So, and if HSCSN is not performing up to speed and the staff are aware of that through their oversight, that could certainly be reflected in the outcome of the next procurement.
Okay. Let's go to maternal health. So I'm glad to see that we maintain funding for the Nurse Family Partnership home visiting grant. Okay, I've never submitted the SPA. I'm really not interested in fighting with you over this today.
It's not a fight. It's an easy fix.
It's not an easy fix.
Why?
It is a fight. It's an easy fix because we already did it. It's an easy fix because you guys are submitting SPAs often. Just slide this one right in there. That's okay. Let me ask you this. Where else is the work to support maternal health reflected in the budget? I know that you guys reconstituted the Maternal Advisory Committee. Can you speak a little bit more beyond just the NFP portion?
Currently, we do have the work. We did get the TEMA grant. I know that was discussed in the hearing. We're excited about that. We have 2 meetings weekly to talk about how we can advance maternal health. We've had work with also our providers. Our Hickory office has really taken the lead on making sure we address,
Your Hickory office?
I'm sorry, Healthcare Reform and Innovation Administration.
Okay.
Get so used to talking in acronyms. And so in addition to that, throughout our fee schedule, we do have various providers that support care. We still have the grant for home visiting this year. We do also have the remote patient monitoring funds this year.
Okay, you do have that. That was
in
going to be my
FY
question.
25, yes. As well as the doula program and our regular physicians. One of the things that we're looking at through the TEMA, and if Joe wanted to come up and add anything in addition to it, is that we're looking at many states are all MCO or they're fee for service. Not many have both. And we want to make sure that we maximize the opportunity to provide the same bundled services across our provider types. And so when you think about, we have DC residents who want access to home and access to care in the community. You also have district residents that want to maintain their care through physicians. And we want to make sure that regardless of whom you're getting your care from, that it is supporting your needs on both sides. So that's one thing that we've been working with the TA department on with CMS in the
Okay.
TEMA grant.
Just for clarity, the remote patient monitoring, is it just for postpartum?
The remote patient monitoring. It can be both.
It can be both. Okay. And is this funding still reoccurring? Or was it converted to one time?
No, it is in the 26 budget. No, it's not available in the 26 budget.
Wait, hold on, back up. You told me that you were continuing this.
We're doing it currently in 25. It
Okay.
is not in the remote patient monitoring is not in the 26 budget. It is one of the things through TEMA that when you talk about a bundled payment and how people can receive those wraparound services, it is included in that model. And so we're looking at how do you create this bundled payment model that also includes the various services, which include things like home visiting. It includes remote patient monitoring and other, as well as other maternal health.
Okay, so this was a council-funded bill/law. This came from Councilmember Gray. We funded it. You're implementing it. And so in the absence of this TEMA grant, we were just gonna stop?
We're not going to stop. I think just as a matter of making sure we could balance the budget and we knew there was an outcome that we would continue it. The care that's being provided on the MCO side, MCOs were doing that without it being in the, as a value add, without it being in our fee schedule or an actual service. So MCOs can continue that in perpetuity in 26 as we design what the overall program would look like for Medicaid across the board.
Okay.
Okay, I won't say anything. All right.
Well, I'm gonna ask sort of a follow-up is, I can appreciate that we're looking at things from like a bundle situation, but when will that be available to a beneficiary?
When's the bundle payment?
I'm sorry.
She wants to know when the bundle payment will be available to support services.
Year 5 of CO. So that would be.
You turn your mic on.
Your mic is on.
Oh, I'm sorry, year 4 or 5 of the grant, which would make it 2028. Oh, 2030.
Wow.
Which one? 2030?
2030.
2030. Okay, so let's just back up here. We're starting 2026, so we are just hoping that MCOs continue to do what they were doing for the next 4 years before we get to,
Well, if it helps, the MCOs have a heavy burden to manage care. And if it helps them in that process, then we would expect them to do it. They would, the good plans would certainly do it. This was a situation where pointedly, the agency dropped the ball on the funding, didn't know we had it. And when we realized that we submitted an enhancement and the enhancement did not get approved. So we are scrambling to try to make sure that whatever resources we have in place with the MCOs and then through this grant will be sufficient to address this
wait, why
problem.
did you need to submit an enhancement when you already had the money?
No, but go ahead.
It wasn't fully funded. So there was a little over $200,000 placed in our budget, maybe about 5 years ago.
Because that's what it cost back
And
in the day. This is the
well-
thing, when we do a law and we fund it based on the FIS that we received at the time.
Absolutely.
But the 200,000 wasn't sufficient to cover the actual service.
We need an enhancement.
Then that is something that we have to take up with the OCFO because we funded what was on the paper. And if they said 200,000, that was what Councilmember Gray funded at the time. What the CFO said the FIS was. So now that 200,000, what is this? When did we do this? 2022. So like 3 years later, yeah, it's going to cost more, but if we're not having those conversations, how will we know?
To Deputy Mayor Turner's point, the agency we didn't implement it. And then when it was brought up, I believe by your office, and they asked for the status, and we realized that we were still relying on the MCOs to provide the service, but we had not actually established the service. So when we established the budget for 26, we made sure that we costed out. We looked at how much it would cost to establish it as a program.
How much is it?
It was the 200 in addition to the 1.7, so about 2 million. Darren, correct me if
But
I'm
that
wrong.
whole bill had multiple components to it.
Yes.
And I know that, I mean, the bill was postpartum coverage. So I know you implemented part of it. You might not have done this part, right? You did part of the bill, which was the postpartum coverage for, so. All right. Just gonna look. I'm gonna circle back. Councilmember Nadeau has joined us from Ward 1. She recessed her hearing to be here, so I'm gonna,
Cost was 1.7 million.
Less. Oh, so 1.5.
what's that now?
1.5 million,
Just for remote monitoring.
yes.
Okay. Councilmember Nadeau?
Thank you, Madam Chair. I have been in the hearing all morning, so if I am asking you something that you've already answered, I do apologize. I want to ask about the Healthcare Alliance first. The DC Healthcare Alliance Reform Amendment Act included in the proposed BSA reverts back to requiring an in-person certification twice a year. Now, this was a policy first put in place under the Gray administration. I believe Deputy Mayor and Director, you were there then.
Yep.
And Vince and I spent years trying to reverse and get back to a place where people were not burdened with twice a year in-person recertification. Under this rule in the past, enrollees would begin lining up as early as 3 a.m. with the hope of getting in when the center opened at 8:30 a.m. It created tremendous workflow issues at Taylor Street Service Center. And often the center would have to limit the services they offered by 10 a.m. because they were already well over capacity and just send people home, having to skip another day of work again, which often led to people coming off the rolls despite the fact that they were still using the services. So why was the decision made to go back to this policy? Thank you.
Two reasons. One, we have a unmistakable challenge with the Alliance program in the sense that there are likely a minority, but a significant minority who establish eligibility and then leave the city. Face-to-face recertification is seen frankly as a way to make sure that if we are paying for, very expensive healthcare coverage, we're doing it for DC residents. And that is the primary driving factor to ensure that the dollars that we spend are going to DC residents.
Aren't you already shifting to a fee-for-service model?
Yes.
So why is it so costly if we're no longer paying on an annual basis, but we're shifting to fee-for-service?
Well, because the fee-for-service model doesn't change the fact that you would have people on, would have eligibility who would not be living in the city.
So you think that people who are still coming into the city for care are not going to be able to come into the city for their recertification anyway and still keep the problem going?
We think that the combination of a face-to-face recertification and the change to the documents that are required to establish eligibility will be sufficient to make sure that we're providing a service to only DC residents.
So what are the changes to the documents?
Yes, there's a change to the document.
What are they?
Can you pull up that email? Sorry. Acceptable forms of verification of residency, either copies or originals, shall be limited to the following items in the name of the applicant: an active lease, rental receipt, or rental agreements for real property located in the District of Columbia, a deed, settlement agreement, or mortgage statement for real property located in the District of Columbia, a telephone or utility bill, water, gas, electric, oil, cable, or landline telephone issued within the last 60 days for real property located in the District of Columbia, a non-expired valid motor vehicles operating permit, or a non-driver identification card that is issued by the district's Department of Motor Vehicles, a pay stub or earning statement issued within the previous 30 days with the individual's name and District of Columbia address, and a property tax bill within the last 60 days for real property located in the District of Columbia.
So why isn't that something that can just be submitted online rather than having to come in person? Seems like those are pretty typical residency documents.
Yes, you can submit those online. But that doesn't change the deterrent effect of a requirement that a person have to show and recertify on a 6-month basis.
And are we doing this for Medicaid too?
Medicaid is, we have Medicaid, it looks like the federal government is going to make us go to 6-month certifications for Medicaid.
In person?
The advantage that Medicaid has over the Alliance is that we have Social Security numbers, and we can check very efficiently, very quickly, whether or not
But
you
you
can
don't have
benefit
to
from
do
it.
any of it in person. There's no reason to do it in person except for to try to get people off the rolls, because that's what it'll ultimately
No,
do.
the goal is not to try to get people off the rolls who live in the district, but to make sure that people who are not living in the district, whether they are on Medicaid or Alliance, do not use district.
But this discriminates against a population that works shifts. I mean, were DHS and FSA consulted in this decision?
I'm sorry?
Were DHS and FSA consulted in this decision?
We made the recommendation from DHCF. We
Was DHS consulted, the service center?
informed DHS. I, as the deputy mayor, informed DHS that we would be doing this.
Does their budget reflect additional in-person staff to take on this
I
additional?
don't have their budget in front of me.
You're
I can't
deputy
speak to
mayor.
it. I don't have that number in front of me, but I will certainly check.
Do they still have increased call center staff that were added to take on the recertification calls?
I'm sorry.
Do they still have the increased call center staff that were added to take on the recertification calls when we changed this law back?
That's not information that I have.
What increased precautions will be taken to protect undocumented residents from being targeted while waiting in line?
DHCF will not be taking any action with respect to that. Our job is to make sure that people have access to high-quality health care. The purpose of the face-to-face recertification is not to expose anybody to.
But it will.
Well, that's your opinion.
No,
You-
it's
you into it. Well, we can't set policy based on.
But it
those
doesn't seem like
challenges.
you've thought these things through because you don't know if there's any additional staff.
We
And
have thought this through. We at DHCF made the decision that we would propose this as a proposal to deal with the growth in the Alliance budget that is almost unprecedented in size. Are you gonna ask me a question and let me finish?
but you're not answering my question.
I'm
You're
answering your
answering
question.
something else.
Well, if you wanted me to answer your question, please give me the opportunity to answer it.
I'm going to interrupt you if it's not answering my question,
Well-
which was about staffing.
I don't have DHS's staffing in front of me. That's my answer.
So what other cost-saving measures were considered? What do you think the increase has been? What do you attribute it to, the increase in costs?
The Alliance cost, the 384% increase since 2011?
Yep.
I'm sure there are a number of factors. I think there are some issues around the population aging on the Alliance program because we've been providing coverage for Alliance members since I came to the city in 2011. So I know there are some legitimate cost increases based on age. I think that baked into these increases are some expenditures for people who do not live in the city. If you look at the claims call, if you look at the claims pattern, there are a substantial number of beneficiaries who have no claims up to 36 months, which is sort of counter to the fact that the population is aging on Alliance. So I think there are a number of factors, but I also think that the fact that we have a program that is completely locally funded, that pays for a range of healthcare services for a population that in some cases has some significant healthcare needs is a principal factor.
Well, I agree that we want to reduce costs, but it seems like instead of taking a scalpel here and actually investigating, for example, why someone hasn't used it for 36 months, we're trying to punish everybody here and just push everybody off the rolls, which I know you're going to say is not your intent, but that is what has happened in the past. We have a very clear precedent for what happens with this policy.
These are the facts. The Alliance program was $51 million in 2011. If we don't make any changes, it'll be more than $250 million in 2026. The CFO informs us that we're going to be without $1 billion over the next 4 years. In 26, the projection is negative. The city's revenues will decline by 1%. So when you have healthcare and human services being the second and third highest costs in the local fund budget, and one of those programs has grown by 384%, juxtaposed against a 1% decline in the city's revenue, we cannot fund that program at its current level. And so we have to propose changes that will slow the growth in what is essentially an entitlement program. And that's what we did.
But you did so in the most blunt, lazy way I can think of.
Well, that's your opinion. I don't think my staff are lazy. If you know how many hours my staff spent nights and weekends running data, trying to figure out what these cuts would mean, how much we would save, who would be impacted, the last thing you would suggest is that we are lazy. We are not lazy.
I'm not suggesting.
You said that.
No, I didn't.
You said we did it in the most lazy way possible.
I think that this is lazy policy.
I disagree.
And what other cost-saving measures were considered? I'm sorry, Madam Chair, I'm a little over.
All the cost-saving measures we considered and opted for the Alliance are on slide 24. That is, we take them out of managed care. Slide 25, I'm sorry. The benefit structure is pharmacy, primary care, hospital-based care, and non-emergency transportation. We established a hard enrollment cap effective 8/1. And of course, we've discussed the face-to-face recertifications, and we've reduced program eligibility to 134% of federal poverty, effective October 1.
I want to turn now to my favorite topic, home visiting. We've previously discussed the mayor's refusal to implement Medicaid reimbursement for home visiting despite it being the law, receiving funding to do so from the council, and our shared goals to advance maternal health in the district. We heard testimony last week that if the reimbursement had gone into effect, Mary Center would have been able to help an additional 100 families. In a year when we're facing so many cuts, this seems like an easy win with a big impact. What other support is DHCF providing to home visiting services?
Sure. Long-term, we are participating in the Transforming Maternal Health Model through the federal government, which is oriented on providing whole person care for maternal health and looking more at a bundled payment that can be inclusive of an array of services that meets the beneficiary's needs. Something like home visiting and something that, and we spoke earlier, the remote patient monitoring, doula services, perinatal mental health, kind of that wraparound of services for individuals. So longer term effort, but it's underway now, and that's where we are focused.
And that's a state plan amendment?
No, TEMA is at this point, it's a grant, and it gives us funding over 10 years to do the work to implement, and it will likely lead into a state plan amendment for the payment methodology portion. But some of that's to be determined since we're just in year one.
Thank you. Thank you, Madam Chair.
I want to follow up on the remote patient monitoring cost.
Good.
The 1.5 or the 1.7, that's both the federal and local share, or is that just the local share?
That's the local share.
That's the local share
Yes,
for remote patient monitoring.
yes.
Okay. All right. Okay. So just to unpack just a minute, you said the bundle payment is year 4 or 5. So what are we doing in year 1?
Sure. And I invite Joe Weisfeld to come up here and he can speak into more details, but we start the planning process, right? Because that's what this takes. So we have, as you mentioned earlier, reconstituted the maternal health advisory group. I think the first meeting was in April, beginning of April, and that really was an overview of the TEMA model and so forth. The second meeting was last month. We focused on, is it provider incentives? Was that last month? I can't recall now. I'm sorry. That there's a focused topic for each month, and that all goes into the planning for how we will develop the bundled methodology. CMMI, which is the Centers for Medicare and Medicaid Innovation, they will give us direction in terms of what model we can use, because they want to see how it's replicated across states. But Joe can go through the details in terms of kind of our year 1, year 2, year 3 milestones.
Hi, Joe Weisfeld, the Director of Innovation at DHCF. So as
Oh,
Melissa
Joe,
said,
you're gonna have to lean into the mic.
it's a little better. All right, thank you. Joe Weisfeld, Director of Innovation at DHCF. The TEMA model, as Melissa said, is a 10-year model. The first 3 years really are more akin to planning and strengthening capacity of our provider network. And so it includes a lot of work around analyzing utilization and payment rates for doulas, midwives, and other types of providers. It also has us working with our community providers to better understand risk assessments and screenings and referrals. It has a number of optional elements as well that we're waiting for a little bit more guidance from CMS. That includes remote patient monitor, home visitation. So there are aspects here that require a significant amount of work on the DHCF side to do analysis, but also we are using these monthly meetings to really hear from our providers on what's happening now, what's working, what's not working, to help inform some of our analysis. I'll also say one of the things I'm excited about that is starting right now is some of the beneficiary engagement that we are doing. We're working with Community of Hope to do a series of beneficiary focus groups. And we really hope that that will anchor each of these conversations when we talk about different service models, different payment models, et cetera. So we are using the CMS framework to really help us have these conversations, but really thinking about how the implications within the district.
Okay. How secure do you feel about this TEMA grant, considering this administration, how they feel about women varies from day to day?
So far, all indications, I feel confident that it will continue. They've made some wording changes, if you will, which I took as a positive sign that it was something that they needed to do to align with their current policy, but ensures that the program is maintained. So we haven't received any signals that we would expect something different at this point. But as you noted earlier, things change up by the hour, but right now we feel confident that we will see it through. And it
Okay.
has not been highlighted as one of the models that will be sunset through the administration came out a few weeks ago noting some of the CMMI models that might be sunset. TEMA is not part of that.
Okay. We talked earlier, I guess, well, not earlier, we talked to performance oversight hearing about some of the challenges that we've heard in terms of with regard to doulas. What I am concerned, and I hope you all say, no, I'm wrong, is that we won't address some of those issues with doulas because we're just going to wait for TEMA.
I mean, I don't know. We're not waiting for TEMA in that sense. The district is, and the district meaning like us as an entity, not the district government per se, is part of the IMI Doula Learning Collaborative, of which DHCF participates too. But I mean, I think some of the planning isn't just planning per se, it's planning so that we can meet the demands and the requirements of the model. And so some of that is planning, but how do we better effectively engage and have doulas enroll in programs? So that's the kind of stuff that's happening now, I think. Like we had a good conversation with our managed care plans about their experiences. They noted, they see challenges with enrollment. I've talked to an individual doula that's been confirmed. So then the conversation is like, well, can we centralize something to that? Or can we have all the plans come together and say, okay, we're going to mirror our policies or our enrollment policies as much as possible, or provide technical assistance holistically. So you're not going from plan to plan to plan. So I think those are some of the things that we're talking about now that we can move forward on later. And then Joe, thanks.
Yeah, I think that's all right. I think we're looking closely at the data and the lack of utilization, and that's one of the activities here. Is why is that happening? Let's look at the data. Let's talk to folks. Let's see what we can improve. And I'll just note that the work we're doing, there's 15 states in TEMA. We're getting highlighted pretty early that we're doing a lot more than the other states. So we are leading the curve and being asked to help other states figure some of this out. I don't know if that's good news or bad news, but that is where we are. There are earmarked dollars in this program for infrastructure starting in the third year of the program.
Okay.
So really excited about that. It's not an insignificant amount of money. We're hoping to announce soon some additional activity, a smaller dollar amount, where we've gotten creative to try to help our high volume prenatal providers as well as doulas. And so that's going to be coming out shortly, but we are trying to be as efficient as we possibly can with these dollars and trying to maximize this opportunity of 100% federal dollars in such a budget environment that we're in.
Okay. Deputy Mayor, I only have a few more questions on healthcare finance related issues, but if you want to take a break now, we can. Okay. All right. You let me know. I have a plan. We're going to take a break after I finish healthcare finance, and then we'll go on. I'm hoping you can give us some clarity about FQHC funding. So, our FQHC leaders pointed out in their public witness testimony that, the data shows that increasing funding for FQHCs is associated with overall lower spending because they're able to catch some things from preventative care early. Now, the budget table looks as though FQHCs are receiving an increase. But I think when we asked you all, you said that's just a rebalancing of funds with more beneficiaries transferring to fee-for-service. So are FQHCs seeing an increase at all, or we were just moving things from one line to another?
So the FY26 budget accounts for the shift of the Alliance program shifting to fee-for-service and FQHCs maintaining that care.
Okay, so the 55 million.
That's 30 million of the 32 to 36 million dollar increase, and you see in the FQHC line.
Yeah.
And to note, it's important that FQHCs will see an increase in payment for the services that they render, because the payment that they would get under the fee-for-service program is the APM payment, which is the, alternative payment model that they get. And so it's based on cost versus the negotiated agreements they had with the MCOs. It increased some costs from $99 to $300. So it's a significant increase to provide the same care to the same people. So we looked at that as one of the advantages, people being able to maintain their current primary care resources, and then now FQHCs getting paid a model that supports their costs more. In addition to that, when we build our provider payment budget, it's not off of FY25. We start new, zero-based budgeting. And so we look at the utilization, we look at the enrollment, we look at any inflationary increases we may do, and we grow the budget. And so that's what we did with FQHCs. In addition to that, we added in $4.5 million to support an expansion of hours. Some of our FQHCs currently have expanded hours, so it's included in their cost, therefore it's included in their rate. But this is something that we wanted to do across the board and make it a scope change and a requirement. And so we added money into the 26 budget in order to do that as a part of the rebasing. And so when you see that $4 million savings, it's not off of the 25. It's off of the anticipated utilization, anticipated spending up to the 26 level. And then we took out the amount that we put in there for expansion. because we can't afford to do it right now. And so with the inclusion of paying more for for the populations that they'll be serving on fee for service, we do believe that their rates will be sufficient. But as always, we'll work with providers. And if we see that there was an error in our ways and there is a negative impact, we will continue to work with them. We've done it with FQHCs before. We've given them increases before when we've noticed industry-wide changes, and we do it with other providers. So
Okay.
even in a tight budget, we'll work with them.
So will hospitals see a similar increase in that the payment for fee-for-service is more than what they would get from MCO?
Yes. It's across those service categories that we are covering on the fee-for-service side for that program.
Okay. Did you want to add something? Okay. All right. Director Turnage, this is, I guess, the first time we've had an opportunity to talk about Cedar Hill publicly since it opened. There's been reporting of very high utilization of the ER, way more than we saw with UMC in those in that final year. And I think based on expectation, not necessarily where it is, they have begun an advertising campaign to try to educate folks on when to use urgent care versus the ER for a variety of different things. And as I explained to folks, even in the community who have called, and it's like, some of the emails that I've gotten have been from people who are legitimately kicking the tires on the hospital. They wanted to see it. They wanted to try it out. And so they might have gone to the emergency room when it really wasn't a necessary trip to the ER, which there have been other people, who've had that. And therefore now they've got longer wait times and things like that. You're on the board of Cedar Hill. What role is DHCF playing in, I guess the better question is, what is the role of DHCF with Cedar Hill now that the hospital has been built and UMC is officially closed? You've just turned your mic on.
Our role obviously is now diminished. Speaking for DHCF, we still have Ben Stutz, who is a director of hospital operations, and he's sort of serving as a liaison between the hospital and all of the regulatory agencies in the city to make sure that there is no error in communication about what is needed, and if there are problems, he helps troubleshoot those problems in his current role. But DHCF, more substantively beyond the liaison work that Ben does, and he's very good at it. He's outstanding. We are setting their rates and doing the same rate analysis that we do for all the hospitals. I will note that they are not being paid yet, and hopefully they will this week cross a threshold with DOH that will allow us to retroactively pay them from their date of opening. So that's kind of, in a nutshell, what we're doing with respect to Cedar Hill. And all of your comments about their opening weeks were spot on. It was UHS informed me that of all their hospitals, UHS has probably over 900 some inpatient beds across the, 900 some, is it hospitals across the country. They said Cedar Hill came on their board as the second highest volume in their system, in their entire system. Yeah, it was a lot.
Okay.
And there are some, every hospital is trying to find nurses, and so that has hampered Cedar Hill's operations a bit. But they're making a lot of progress in identifying nurses. And to be frank, the outpatient has not opened because of their struggles with a GWMFA, UHS getting a deal that they can all agree on.
I'm sorry, outpatient is not open yet?
No, not open yet. They are targeting mid-July. Hopefully there will be an agreement between GWMFA and UHS. They said they were talking the last 2 weeks, so hopefully it'll be sometime soon.
They already had that agreement. Was that agreement only for the hospital emergency and acute care operations as opposed to outpatient?
No, the agreement was for outpatient. It was not signed, and I think a lot of things have transpired since those agreements were being discussed. UHS is looking at them with fresh eyes, and frankly, GWMFA, as everybody knows, based on the reports, has some really significant financial problems.
Okay, well, I'm gonna just say this because I've been asking for this agreement for weeks,
Yeah.
actually months at this
So have I.
particular stage in the game. I have gotten an invitation to visit the hospital, which is not an agreement,
Right.
in my opinion. You're on the board.
Mhm.
We've asked some basic questions of like, who are the board members? Who are the members that the mayor appointed? You know, I was eager to begin to treat Cedar Hill as all of the other hospitals where I don't have to be engaged in, you know, this type of pieces, but like the agreement is kind of key. And yes, you're right. GWMFA has had issues, which is why I was asking for the updated agreement. And now because of this, I know I'm going to get a call from the GW Hatchet to ask some questions about this going forward. So let's follow up on this offline.
Yeah.
So long-term care. Can you guys explain a little bit more the changes to the quality payment methodology that will result in nearly $1 million in cuts, or rather savings, if you will, for home health aid services? You know how people feel about their PCA hours.
Yes, and one of the things, I know Melissa mentioned earlier, we're doing a home health study. It's a rate study, but it goes beyond that. And I think I talked about it in our previous hearing. It focuses on the service gaps that we have. We just got a report from our contractor that we're reviewing now that talks about the service gaps. And we're looking at a bundled model for many reasons. We're utilizing PCA services that are not aligned with what PCA services is supposed to be. So we had to ask ourselves, well, what does that mean? And we have to focus on what type of care is needed. For example, if we're talking about keeping people at home so that they can receive their care at home, it's not PCA services that they need 24 hours. PCA services generally may take 4 hours at the most. So you look.
So what's the
in-home
alternative?
support. So the alternative is making sure people are accessing the services that they have. We have other adult day health programs. There are other services that are out there that are covered by Medicaid that focus on a patient's need. There's skilled care. There's also the savings that we can generate by really looking and making determinations from a clinical base. Does a person need 24 hours of home health, of PCA services, or do they need more skill type services? Are they utilizing PT and OT speech as they should? Or are they just relying on having someone that's really doing in-home supports? And by putting it in a bundle, what you allow the home health agencies to do is have metrics or have services that they're required to provide, but you provide them a single payment to provide all of those services versus a unit base where you're paying these 15-minute increments. So you're paying for increased utilization when that may not be the answer to that beneficiary's need.
But do our home health agencies have the capacity to provide these other types of services if you're going to
Yes.
start doing the bundle? Like how many of our home health agencies are also providing OT or PT?
They should be. They're required to.
You said
It's
should.
covered. Their complaint is that our reimbursement isn't sufficient, and that's why they're not doing it. But they do provide it, especially when you look on the MCO side. And then with United, when they have the agreements with MCOs, you'll see them do it more on that side. There are a few that do it on the Medicaid, the fee-for-service side. And so by looking at, like right now, they'll use an RN to go give medication versus having a certified medication assistant be able to provide those services.
Well, technically, this is an issue from the other agency, right? We've been asking about the certified medication assistant
But that's
from
all.
DC Health. You're not my DC Health person. What I'm saying is that like, when we're making these types of, we're going to make a shift, are we talking to the other agencies to say like, are you ready? Because DC Health has not been ready on the medication aid certification program.
Right, absolutely. I think it takes us to come together to determine what those service gaps are and what are the flexibilities we can provide. And providers let us know where they feel we have shortfalls, and they let us know what they're willing to provide. I think we focus so much on non-clinical care by providing safety and making sure that someone is there with that DC resident, then we focused on, we say we want better outcomes, but the services that we're providing, we need to make sure they align with that expectation.
Yeah, but I mean,
So-
okay, so let's say if we did this
Mhm.
and, someone who is homebound, they want to receive services in-house, they are going to get, I don't know, an hour of OT. Is the idea that for that hour, you wouldn't have a home health aide there, you would have the OT person who is there?
The idea is that that home health agency would have a bundled rate to provide all of those services. And bundled rates require more efficiency, and so you would get savings there. We're also looking at acuity base.
I know, but
The question
I'm not talking a workforce question though.
Mhm. But
Right.
that saves money, though.
Why, if
Depending
I
on
would
the
be sending
workforce
two
that you're
people,
utilizing.
assuming that the home health aide who I have can do both?
You're paying one rate. So if the home health agency chooses to send all 3 people out at once, that's a cost that they're incurring outside of their rate. What we're saying is whether you have a PCA, a CNA, or you have the requirement to have nurse medication provided, or PT and OT and speech, it's up to you and your interdisciplinary team to work together to figure out a work plan. And for that work plan, for that population within that bundle, you will get paid a specific amount, and you have to utilize that amount efficiently.
You have a lot of confidence in the home health.
But we're not going to performance. I think if we went to performance-based, I would be on the same page with you and say our home health agencies are not ready.
Yeah.
And that's why we're taking those baby steps to get to value-based, because we don't want to create a system that's not reasonable, but they need to take baby steps because we need them to be at value-based. That's where healthcare is.
No, I understand. I just don't want a resident to get caught in the gaps of a home health agency trying to get their act together. Because it was not that long ago, we were talking about your inability to complete a rate study because the home health agencies were not providing
Cost
you
reports.
the cost reports,
Yes.
which I feel like is a very basic thing that if you're running a business, you would have. But then you go and visit some of these home health agencies and you see, oh, you don't really have a back office. You have like one person holding down the fort. So as we're sort of making this shift, right, like I feel like we're going to hear more complaints of someone saying, I used to have 24 hours. My home health agency has now changed in terms of methodology. They sent someone to do my OT, but then I had to go to the bathroom and then the OT person said, well, that's not my job. You know what I'm saying? Like, I feel like we're going to get to this. It could fall apart very quickly where people are like, oh, that's not my scope. You're going to have to wait until so-and-so gets back to be able to do that because they don't pay me to do that.
I would hope that our home health agencies are professional enough, and I believe that they are. It's the same circumstances that happen now, whether you have a nurse there, whether you have your PCA there. I think the shifting that we're talking about is actually giving them more flexibility versus reducing their flexibility and their capacity to provide beneficiaries' needs. But again, we're in the planning phases, but what I can tell you is the data that we have looked at, the diagnoses that our clinicians have reviewed, the way that we're utilizing our services does not align with the way that our district residents need services for habilitation. And we are responsible for making sure that that happens. And so even looking at acuity-based, it may not be everybody at home should be safely at home receiving their care. And we have other options. And so other things that we're looking at is things available through assisted living. If someone needs 24 hours of care, but they want their own apartment, they want that privacy, how much is that? how does that allow them to
Yeah.
still stay in their community? So looking at different shifts. So we can keep you updated on the rate study and what we're finding out, but
Let's
the
keep
$1
talking about that, because I think for some, yes, I would agree with you. There are some people for whom they might be better served in a different environment, but they're attached to their home, right? And obviously they have a personal decision or a family decision that needs to be made in terms of that. Then I think there's also the question of like, do we even have space and beds available in DC to be able to transition folks? So like somebody doesn't have to go to Maryland or otherwise. So let's keep talking
we will.
about all of those. We did hear from a public witness last week that despite nothing changing about her health status, her Telegen assessment resulted in fewer home health hours and a lapse in coverage. What changes, if any, did healthcare finance make from the Liberty contract to the Telegen contract? Hello.
Hi, good afternoon. Benjamin Abebe, Long-Term Care Director. So we didn't make any changes. We transitioned February 1, 2025 from the past LTSS assessment vendor, Liberty, to Telegen Healthcare. And from our analysis, we haven't seen those changes that you're referencing.
Okay.
It's only been processing backlogs of assessments in the month of February and March, and we're all caught up. There wasn't anything substantive that was
Okay.
done from an assessment.
Can you all follow up with the constituent who testified?
Yes, we can.
Okay. All right. Let me ask, any updates on the 1115 waiver?
Not really. It's the current waiver's been extended to at least I think it was end of June or so. We anticipate another extension, and I don't think we'll hear anything until more towards the end of the calendar year in terms of approvals.
All right. Okay, we'll come back to that. I'm gonna keep all my thoughts on that one bottled up in terms of CMS. Okay. There's a behavioral health stakeholders engagement contract for $82,500. What is this? Who are we engaging with? It says behavioral health stakeholders engagement contract. We have it for $82,500, and I know that seems like a low amount of money, but in this type of budget cycle, every dollar counts.
Where do you see that?
It's in your contracts and grants attachment.
Oh, is that in the,
Yep. Okay, it says TBD vendor, but in your contracts and grants line, you have behavioral health stakeholder engagement contract. There's no PO or anything like that. So this is a new situation, it seems.
Councilmember, what program does the answer, does it say what program it's under?
No, it all says TBD. If you're looking for it, it is right above your contract with Burt Smith for adult nursing. And right below your ASO contract. On the same page as LexisNexis. Which, unlike Doge, I know why you have a
Does it-
subscription to LexisNexis.
Does it say, I'm sorry, does it say behavioral health specialist? Because that's not new money. It's one,
No, it says behavioral health stakeholder engagement contract.
okay.
This is giving us great confirmation to take that down.
So my apologies. I'll get back to you. I'm not aware of what that contract is. And I'm looking through the contracts now, so by the time we finish.
Okay, all right.
Okay.
Okay, we're actually, that's my last one specifically related to healthcare finance. We're gonna take let's take a 7-minute break. We'll come back, we'll do, DMHHS. My request, because I know that I have some colleagues who are in the building, is that the healthcare finance team not leave, just in case a council member comes that has specific questions that are healthcare finance related, since you wear both hats. Is that okay? Okay. And just so you know, I don't have a lot for DMHHS, so we're gonna be wrapping up here. Okay. All right. So let's take a 7-minute break and then we'll come back. Thanks.
Yep.
Okay, we're back. All right, so we've got a new crop of friendly faces. So I need to swear you guys in. So if you could raise your right hand. Do you swear or affirm on an ability of law that the testimony you're about to provide to the Council of the District of Columbia and this committee is the truth, the whole truth, and nothing but the truth? Okay. Deputy Mayor, before you begin with your testimony, I'm going to give a PSA for the council colleagues and/or staff who may be listening. I don't have a lot of questions for the Deputy Mayor on the Deputy Mayor for Health and Human Services. So if you have questions or your boss has questions, I would highly suggest that they make their way to room 500 in the next 10 minutes. Thank you. When you're ready. You turn your mic on.
Good afternoon, Madam Chair. I will be very brief in my opening remarks. I want to start by sort of reminding the audience of the core functions of the Deputy Mayor's office. We have a policy team, we have an encampment response team, and we presently, we used to have an age-friendly DC permanent employee who's since retired, but is now helping us on a volunteer basis until we can get that position filled. And we also work closely with ICF, who's represented here by their wonderful director. She has a data team, operations and member relations shop, and she does excellent plans and reports. Kiana is to my right, and you know Kiana well. She's my chief of staff, and she is responsible for the execution and implementation of our office functions. And of course, we have our AFO at the table with us as well. I wanted to I typically try to stay away from the things that the other agencies are doing in our cluster because they are much better representatives of their successes, and they can explain their failures better than I. But I do want to just briefly mention, and I probably going to kick myself for doing this, some of the key things that we have been involved in is obviously Cedar Hill that we've discussed. I think the Stabilization Center has been a smashing success, and as has the Aston, which was opened recently and is now a valuable tool in our homeless services program. And you know, with those tools and the investments that the mayor makes in both homeless services, even on the Medicaid side, the whole, and to spend dollars to increase the continuum of care for homeless services, including access to 24/7 shelter. And of course, we have a huge effort with our efforts to battle the pernicious challenge of opioids. That is ongoing. But again, the agencies can talk about that a lot better than I can. So I'm going to, our budget is relatively small. I won't, after dealing with the massive numbers from DHCF, I won't bore you with the what is essentially budget dust in comparison. So I'm going to basically stop and open up for questions. And we are happy as a trio to answer any questions you might have. And of course, if there are budget questions, the AFO can, that Kiana can address, the AFO can address those as well.
Okay, great. Well, that was unanticipated, but appreciate it. So let's start with age-friendly DC. You know, what's your vision for age-friendly DC moving forward now that the former director has retired? Do you think that this project could better support residents aging in place in the district?
You know, the first vision is to get a permanent director. Our previous director, Gail, was outstanding. I see age-friendly DC as, you know, I think it's an incredible program. The stuff that we do for the elderly who are living in their homes is tremendously noteworthy. and then the community programs that we have in place. I just think that I don't think there needs to be a change in the focus of the program. Resources, we can always use more resources, but I think we should continue in the direction that we're moving, especially as it relates to making homes safe for those who choose to live and age gracefully in their home, and offer as many community-based programs that we can offer to give residents an opportunity to come out and interact and avoid social isolation. So I don't see a need, and Kiana may feel differently. I don't see a need to change direction. Maybe we can intensify resources over time.
Okay, I would say this, I mean, we talked a little bit about this at performance oversight, right? Like, we have a need for some real long-term care coordination amongst the various agencies who dabble and work in this, whether it be healthcare, finance, behavioral health, DACL, disability rights, or excuse me, disability services, et cetera. And I thought that the age-friendly program would do that, but then we saw the survey where you did an age-friendly survey and the vast majority of the respondents were like under the age of 40, which doesn't exactly go to what I thought the goal of the program was, which is around as folks age, being able to live and thrive in the district.
I think that is the primary goal. Certainly, there is a need to make folks who are not in the category that would label them as elderly to understand some of the challenges that the persons who are aging gracefully in the city actually face, and make them a part of the solution. I'm certain. I can't imagine why there may be some not selection bias, some non-response bias in a survey for age-friendly that basically underrepresents the folks who are actually benefiting from the program. But there is a broader focus on the city's environment overall that would, I believe, it reflects the desire to keep people involved and informed about what needs to be done to ensure that people can live and age gracefully in the city. So that probably reflects more so the focus on the persons below 40, but I think if you look at the activities, they're more focused on people who are, elderly like me.
Okay. Have you all posted the position already?
Mm-hmm.
Good afternoon, council members. So just a couple points on the former point you were highlighting. I think with age friendly, and we're happy to provide some of this information, but the idea and part of the respondents to that survey is that it's not just focused on older adults, but it's supposed to focus on different ages across the lifespan. There's actually an age-friendly task force meeting this week, and a lot of the work is focused more so on other interagency coordination, not so much long-term care, but I think in recognizing the concerns on long-term care, there could be room for that, but it wouldn't necessarily be aligned with the age-friendly task force, and then also the way that the actual order is written for age-friendly.
Okay, maybe the focus on long-term care was a misspeak on my part, but I have a lot of agencies across the whole government that have significant interaction and touch points with seniors. And there doesn't seem to be a lot of coordination happening to make sure that, number one, we don't have multiple agencies who are duplicating efforts. And two, being able to look at our entire continuum to identify where there are gaps in terms of providing services, et cetera. When we think about the function of the deputy mayor's office, it seems as though this would be the work that you all are doing, but it doesn't seem like you have a person in your office who is focusing on this population in particular, even though you have an age-friendly project. Would you agree with that?
I think there's fairness to that comment. I think the way that, so each time the age-friendly for the different years, the order is usually between 4 to 5 years. There's different scope of work that's included in that goes along with ARP and what the national organizations are doing. So that was not an area that was identified in there, but I hear you on the comments of where we recognize with the challenges of long-term care and then the role of coordinating. So I think we would just have to rethink that position if we're able to hire. And to answer your other question, the position was posted and closed. So we had several applicants, but it closed the week before the mayor's order went out about the hiring freeze.
Oh,
So a lot of the vacancies that were in our office all got caught up in that. So we have positions that were funded and ready, but we aren't able to hire currently. And it was one of those vacancies.
Okay, thank you. The proposed DMHHS budget reduces the funding for the Interagency Council on Homelessness by 110,000 in contract funding, as well as 1 FTE. What was the rationale behind these cuts, and what will its impact be on ICH operations?
Thank you for that question, council member. There were 3 categories that were identified for those operating costs. The first was the development of Homer DC 3.0 and very specifically the data analysis associated with that, the modeling that was included as part of the first and second iteration of Homer DC. We also identified operation costs and consumer stipends for a robust and comprehensive lived experience advisory group. So let me walk you through kind of category by category what the decisions were. For the development of Homer DC 3.0, we recognized that the modeling that's needed is just not on a one-time basis, but is actually an ongoing basis. And so we decided to restructure the staff of the ICH and make sure that there is a data team that is able to actually support those. So we have pivoted from making that a non-personnel cost to a personnel cost item. With regard to operation costs, especially the in-person quarterly meetings are covered in this cost category. It continues to be a need. Additionally, we have 1 philanthropy-supported FTE that is currently supporting the ICH. We think it's critical when we are onboarding a team of 7 new FTEs that I continue to be supported and that I can successfully onboard the 7 staff people that have been identified. So we are earmarking that as the major cost category that I need to continue to be supported around. And then lastly, in terms of consumer stipends, until I'm fully staffed up, that is not something that I can administer. So we decided to forego that in the fiscal year 25 budget. So when we were identifying potential cost savings with regard to the congressionally imposed cuts, we identified 2 major areas of savings for the fiscal year 25 budget.
Okay, thank you. While we're in this area of conversation, Deputy Mayor, can you provide an update on the Ashton and how DMHHS envisions the opening of that shelter, decreasing the need for encampment clearings?
There are, as I mentioned in my opening remarks, brief as they were, this is one of the, the successes in our homeless services program. There have been, first of all, a very positive response with the neighbors after some real concern about whether or not this was an appropriate facility for their neighborhood. They have really embraced it. We have 83 residents in the building, and we expect 5 to be transferred in from a transitional shelter this week. That number will go to 88. Excuse me. The average length of stay is about 72 days.
You said 72 days?
72 days, yes. And the census includes 71 individuals who were unsheltered, with 62 matched to a housing a voucher. We see it, excuse me, as a valuable resource in our effort to reduce homelessness. It is like all of our facilities; they are under the pressure of the growing demand for homeless services. But this has been a jewel so far.
Okay. We heard some public testimony voicing concerns about encampment clearings, including the shortened notice that DMHHS is providing individuals living in the encampments. How often are you guys only providing 7 days as opposed to the 14-day standard?
I can get the number. We switched from the 14-day standard maybe, I don't know, a month ago, 2 months ago, maybe a little bit longer. I can get the exact date. So right now, the protocol is for a 7-day notice.
For all instances?
Yes, that's the protocol. Now,
Well, as opposed to immediate disposition?
right, immediate disposition, yeah, they'll do it, they can do it the same day. And certainly our staff is very experienced, and if they sense that, more time is needed, they can certainly make the adjustment. But 7 days is now the protocol, and we are, focusing on encampments that violate city regulations that says you can't encamp on public land. And we certainly, our goal is always when we close an encampment to offer a shelter bed. Now, that is challenged, and we have to figure out a way to deal with it by the fact that the shelters are now full and will probably be that way absent some intervention until we go back to hypothermia season. So we have to, and I get emails daily from the encampment team, have we figured out the shelter problem yet? And the answer is no so far, but we will figure it out.
But you just said the shelters are full.
Yes, so we have to figure out how to bring on more beds. When we close an encampment and we offer a shelter bed to everyone, the reality is only about 5%, if that many, accept the shelter bed offer. But you still have to make the offer, and you have to have a bed for the number of people who are in the encampment that you're closing to make your efforts credible and humane. And so that's what we strive for. So we have to figure out a way. I'll huddle with the CA on this issue and see if we can figure out a way to, create some beds that will allow us to ensure that when we close an encampment, people will be offered at least a shelter bed.
Okay, when you all changed the standard from 14 to 7 days, did you update your documents to?
Yeah. And they're on the website. Do you remember what the date we did that? Yeah.
Okay. All right. I mean, it's one thing to have a shortened timeline. It's one thing to try to respond to support MPS or Park Police Service when they have situations and they want us to support. But if we don't have any place for folks to go, I'm concerned sort of about the compounding factors here, right? So I've got a more speedy timeline on encampment closures. We're making some significant changes in rapid rehousing. We're having still some challenges in terms of leasing people up in a quick manner on LSRP and other things. Like, I don't want us to go back to the problems that we used to have. But in some ways, it feels like we're doing a lot at once without making sure that all of the infrastructure is in place.
The system is under heavy pressure. There is no question about it. And I don't think that's going to change in the near term. The number of residents who are seeking homeless services seems to grow unabated. And not all of them are DC residents. We have very porous borders. And, officials in Virginia and Maryland, will tell you offline that, when they see, when they have people who are looking for some quality homeless services, they will refer them to the district. So we have to deal with that. It's the reality. It's the magnet that a robust homeless services program creates. We just have to find a way to deal with it. And it is not easy. And the problems that surround people who are forced to live homeless are significant. I grow an appreciation every day of how difficult this is. And there's just no easy answers, and the resources are getting strained, to be very clear.
In terms of a shelter that we recently opened, the Ethel
Yes,
Hillies.
it's been a while. We opened that several summers ago.
Oh, go ahead.
I think so, yeah.
Yeah, I know it's been about a year.
Yes.
No, just a clarification, I don't think the Ethel is a shelter. I think it's a permanent supportive housing project, but
Okay.
maybe I'm misspeaking.
No, you're right.
But there is a women's shelter over there, perhaps.
Harriet
Are you talking
Tubman.
about Harry
Yeah,
Tubman?
Harriet Tubman,
Yeah.
sorry. Apologies. receiving some complaints about the state of that particular shelter as well. And this is a thing, right? Like we've got a number of shelters in our portfolio that need updating. We focused on family. Now we gotta go back to the individuals. And I know that the budget includes some funding for a few.
Yep.
But it's gonna take some time. So in the effort of we offer shelter beds to everyone, you have to acknowledge that not every shelter bed is one that is in a facility that is desirable.
Yes, I mean, you know, the operational cost for our shelters is more than $100 million a year. And that's the operational cost, and it's not the cost of improvement. And we are spending significant dollars on improving shelters and opening, non-congregate facilities. So I'm not particularly aware of the complaints around Harriet Tubman. I don't know if Kiana is.
So Councilmember, to speak to that point, I will say, and Teresa can expand more on this as well, but we recognize that different shelters, particularly when they're congregate spaces, are not preferred by clients. So the Aston that the DM was referring to earlier, for example, a majority of the residents at the Aston were coming directly from encampments. There are some caps. One cap was lifted back in February of this year at the Aston. So now that we have more capacity, we can be thinking about that. Regarding the other investments in shelters, there is one that's slated for this year that could potentially help serve some of the issues that you're alluding to. The others would be in the out years, just based off of the capital budget, but we can double check with DHS on what all of those would entail. But we've also heard some of the concerns at Harriet Tubman specifically.
And I know there's been a request that we stop encampment engagements. And I just don't see how that would how that would work.
Stop what engagements?
Stop campment activity, campment enclosures, campment cleanups. I just don't see how that would serve either the residents who are experiencing homeless or the city very well. I mean, if you stop cleanups and closures, you would soon have, it would be a return to what we saw at McPherson Square, what we saw at Noma, what we saw at New Jersey Avenue Park. And once encampments get that large, it is a very, very difficult struggle to close them humanely and without, tremendous pushback.
Yeah, well, I mean, yes, we don't want encampments to be that large anymore. I have concerns, obviously, about individuals who are on federal land and the changing posture that the federal government has in that, right? Like, I don't want to see what that develops into. Yes.
Yeah, if I may, there are two strategies that the ICH and its like members have been pushing us to consider in this area. One is a call for all transitional housing resources that are operated or funded by the district outside of the DHS portfolio.
Okay.
So to the extent that other agencies are also funding temporary or transitional housing resources, that it might be really important to look to those other areas. Our PIT count allows us to think about the various vulnerabilities of the population that we serve, and to be looking to partner agencies like CFSA, DACL, any of the other agencies that have an overlap with the population that we're serving, to see if they have temporary housing resources that we could leverage to benefit homeless services.
Okay.
The second strategy, like you mentioned, is to actually expedite lease up. So to ensure that everybody that's matched to a housing voucher is able to take advantage of that, because if we move on to housing, that helps free up beds in our low barrier and temporary housing shelters for those who need it.
Yeah. Speaking to the first strategy that you talked about, what is the timeline on that, right? Because we got lots of agencies who have what we refer to as special population vouchers that have gone unused, even in your own cluster. Like,
that's exactly right.
DBH has vouchers they're sitting on.
We actually are hoping to have a memo in front of the DM and the city administrator by the end of week so that we can mobilize our partner agencies. That's what we've been working towards.
Okay, that's good to hear. I mean, on that, in terms of how we mobilize, Deputy Mayor, I know that you attempt sometimes a more hands-off approach with the other agencies in your cluster, but this is now my official public request for you to lean in on some of them. We've heard significant concerns and testimony about St. Elizabeth's Hospital, which is a hospital still in our portfolio that we operate, that we run. And this is from staff about unsafe conditions and things like that. And frankly, when I look back at the budget for St. Elizabeth's, FY24 to now, or what is being proposed in FY16, it's like a $16 million reduction at St. Elizabeth's, even though their population has changed. Where it used to be 60-40 forensic versus community, they're now over 90% forensic. And they have not made any changes to security or staffing to accommodate the change in population there. Let me ask this. When's the last time you visited St. Elizabeth's Hospital?
The last time I visited St. Elizabeth's Hospital was, it was following an incident where a resident was badly injured. And it's been a while, but I talked to Barbara Bazaron regularly about this issue.
I know, but you asked Dr. Bazaron, she would say everything is fine.
No, she doesn't say everything is fine. She doesn't paint as negative of a picture as the staff who testified does or did. But she thinks the problems that were identified in some cases were exaggerated. And to be clear on my I will call it a philosophy, for lack of a better term, for as you would call it, hands off. It is, my first recognition is that the mayor has hired competent directors, and I can't run their agencies for them. However, if there are issues, challenges that are operational in nature and are not, or even policy, and are not effectively managed by the agencies, I don't have any hesitation about getting involved. And even if I did, the CA would direct me to get involved. So my conversation with Barbara was about the testimony and trying to get a sense for how real that was. And she and I will have endeavored to have a few more discussions. And if it takes, a visit for me to meet with the staff at St. Elizabeth, including not only the C-suite team, but some of the leaders, I will do that to better understand exactly what the problem is and what possible changes are needed, if any.
Okay, I'm asking you to do that.
I will do
To
that.
meet with the staff, which I feel like they're on the floor, so they have a very different picture than management in terms of what's happening. What I don't want to happen is the same situation that we had in 2019.
Sure.
Where a nurse was severely injured at the hands of a resident who was there. And I have pause when I hear that the facility only has 7 security per shift for the entire facility, both inside and out.
Mm-hmm.
But you have somewhere of 95, 96% of the patients are now forensic. The medical unit at DOC is better staffed than we have at St. Elizabeth right now in terms of comparison, right? When I talk to the health staff at Unity about their experience at DOC versus talking to some of the folks who are on the floor at St. Elizabeth's about their experience there. And I am concerned, I don't want us to have a problem.
Sure.
That
is fair.
Becomes larger there. We've got some other programs as well. School-based behavioral health, where we are continuing to keep a significant amount of money in that program, even though I still got over 50% of the schools who don't have a clinician, and there doesn't actually seem to be a plan to improve besides pilots that I don't think is really going to address the problem because the providers are telling you what the problem is, which is the overall size of the grant. But I have an agency that is refusing to engage on that. And then finally, I mean, our entire opioid response for the city is dependent upon federal grant money right now. Does that concern you?
Well, it concerns me if it goes away. I mean,
You could go tomorrow. Like,
there's a possibility it could go away tomorrow, but it has not. And I think our opioid response, the numbers are suggesting that we're making some progress. I can guarantee you if opioid funding if the funds were eliminated by the federal government or substantially reduced, given the nature of their problem and the significant public health and public safety concerns that would create, there would be a response. Right now, we are seeing, we have tremendous momentum. Fatal overdoses are down by, I think, about 35%.
they are, but our non-fatal overdoses are up. If you talk to FEMS,
Well, I thought the numbers today were down by 6%, non-fatal.
non-fatal are still high.
Yeah, okay, but
And maybe I haven't looked at the dashboard in the last week in terms of the data
I haven't looked at
there.
it last week.
But so here's the intersections too that I'm also concerned about. If we look nationwide, of the people who are receiving SUD treatment, about 47% of them are on Medicaid.
Yes.
We're about to make a significant shift in our eligibility of terms of Medicaid population. And now that I think about it, I didn't actually ask Mila around whether or not SUD coverage exists in a basic health plan scenario, which we need to follow up on that. I hope it does. But like, are we gonna see a reversal? Because what overall in terms of this budget, I'm hopeful that we are building in plan Bs and Cs because this federal government is so unpredictable. And I feel like if they go through with some of these changes and these cuts, the compounded impact for certain folks in our city is going to be doubly more than what it is for other folks.
I can assure you that the persons who are in charge and the directors of these agencies are thinking regularly about what would happen if some of what is threatened at the federal level actually occurs. Now, we don't put that in a budget plan because, you know, it would vitiate any savings that we put forward because it would be costly. The CFO would say, hey, if you're planning to do this, then you got to pay for it, which is his job. But that does not stop us from huddling and thinking about what the response would be if, for example, this program is cut or this funding source is completely eliminated. We do that all the time. And while it would be a difficult and heavy lift, we'd have to find a solution. And we would certainly make proposals from the agencies to the deputy mayor's offices directly to the CA when we see these problems. He gets memos from us all the time explaining what we see as a challenge or a risk, and we have meetings with him. I meet with him twice a week, and we discuss all of these issues. So
Okay.
he's aware, and we are aware.
All right, so just in terms of the data, non-fatal overdoses are up 11.6% for the prior month. We had 453 incidents. So, I mean, our strategy in terms of naloxone, we're getting there. We've put it out on the street, and that's all happening. I'm glad the number of fatal is dropping, but the non-fatal number can flip on us on a dime. And, you know, when I look at this particular administration, they don't really care for SAMHSA. At least that's what the president's budget would suggest. So, you know, I think we're
No,
I know you can't do the double budgeting, right?
Right.
But I think we are looking, and I think the public is looking for some reassurance that one, these conversations are happening, and two, we have an action plan. Because things seem to be moving very fast and furiously, and we don't have the luxury of going 5 or 6 months to wait for district government to sort of catch up to where the federal government is moving on some of these policy changes. We talked about this kind of earlier with healthcare finance, but it's the same in terms of needing the deputy mayor's office to lean in terms of some of the issues with DHS. It's not just about the customer service for folks, but like that SNAP error rate That's $79 million we would have to add separate and apart from admin and now needing to pay the share of beneficiary costs. And nobody would see an increase in their payment. That's just us from mistakes that we have made. And I brought this up and I've brought this up with DHS. Nobody has a plan. They're cutting overtime. They're saying we're going to be efficient. They're on a hiring freeze. Like, somebody's got to do something, because now it's starting to mean something from a dollars and cents standpoint.
The system is there to make sure that applications are processed properly and on time, and we just have to figure out what's going on in the execution of those applications that is creating this problem. I don't think they're unaware of it. We just got to figure out the best way to deal with it, because there are no major system changes you can make.
I know, it was testified to that. This
Yeah.
is what I'm saying. There have been other things that have come up as
Sure.
big flashpoints in this city where your office has risen to the occasion to do the coordinating. When we had an encampment problem, you came to the table with a pilot, with a solution, and we worked on it. It was not easy. It was not quick, but it felt like it had the attention of the executive to address that problem. What I'm saying is we got some other flashing problems, and I don't see the same type of attention yet. And we don't want the bottom to fall out before everybody starts to pay attention.
Why don't you and I have a discussion about what these flashing problems are, and
Okay.
then I can sort of work in, a process to address those.
All
So
right.
I want to make sure I'm on the same page with you.
Okay, I appreciate that. And it's not everybody.
I know.
It's not everybody in the cluster. I want to be very clear on that. And I don't have any further questions. I don't think any of my colleagues have joined online. So I'm going to give you opportunity if you have any closing comments you wanted to make.
No, I just want to thank you for your hard work and for the recognition that we are in uncharted territory. Human resources and healthcare is just a dominant part of the budget. And, these things are under heavy scrutiny at the federal level, and they could bring some changes that will be very difficult for the district to absorb. So we look forward to our continued partnership with you to have an exchange of ideas and about how we can proceed in a way that benefits both the residents of the city and the agencies that run this program. So happy to do it.
All right. Well, I want to thank you for testifying today. I want to thank the folks on your team for not just answering your questions today, but I truly feel as though it has been a good collaborative conversation. You've answered all of our questions that we've had over the last couple of months as we're sort of working through this. When I have community conversations with folks about the health portion of the fiscal year 26 budget, I do inform them that this was not something that we started in March. We started conversations early enough that we were at least able to get a plan in place in terms of how do we transition folks to make sure that they're able to keep coverage. So I also want to thank Director Kaufman and her team for their testimony as well. I don't have any further questions. Again, for the public, if you want to submit written testimony for the record's open until sometime next week. You can upload your testimony on the Council Hearing Management System website. Our next hearing for the Committee on Health will be on Monday, June 16th at 9 a.m. We're going to hear government witness testimony for our DC Department of Health. There being no further business before the committee, the time is 2:20 and we are adjourned. Thank you.
That table came in handy.
Yeah, it did. Also so much faster.
Yeah. When Nadeau left, I was like, oh, nobody that actually cares about homelessness.
It's gonna be fair.